other neck. You want to go further down? Turning down my arms now. Everyone will follow my example.
Well, good morning, everyone. Thank you so much for taking the time to be here on a Saturday with us. I'm Dr. Savage. I'm a melanoma medical oncologist here at the University of New Mexico's Comprehensive Cancer Center. And this is the first time we've been able to offer this opportunity to survivors of melanoma and their families. And it's in a collaboration with AIM at Melanoma. This is a national and international patient advocacy organization that does events throughout the world. They also build communities for people who are going through a journey with melanoma. They raise money for melanoma research. And they reached out last fall and asked if we would be open to doing one of these symposia here at the University of New Mexico. And I thought it was a great idea. I've had the opportunity to cross paths many times with AIM at Melanoma. When I was a resident at Cleveland Clinic, I had a really wonderful melanoma mentor there named Dr. Funchain, who started the AIM at Melanoma Walk in Cleveland, Ohio. And that was my first introduction to this organization. Then when I was later in San Diego, my second melanoma mentor, Dr. Bolin, got approached by AIM to do a AIM at Melanoma Walk in San Diego. And they just had their third annual walk this past year, and it's very successful. And via these walks, I've been able to meet other people in the organization, including Sam Guild, who's the executive director of the organization, and Anne, who I'm going to introduce to you in a moment. AIM at Melanoma, for those of you who are not aware, has a lot of really great resources on their website for people with melanoma and their families. And I try to point people to this regularly when I meet them in exam rooms, because you all have many questions about this process and what treatments are on the horizon and what things a person should expect when they're going through a journey with melanoma. And I feel like AIM at Melanoma does a wonderful job presenting information in a way that's very digestible to anyone, so that it's not just a bunch of articles and links to PubMed, but truly things that are written in a way that you can understand it and understand what the implications of all of these data are to your life. That is the goal for this symposium today. We have several speakers who have invested a lot of time into the topics that we asked them to present. But the focus is on all of you. It's not presenting this to healthcare providers or other doctors. We do that regularly at our national conferences and our regional conferences, but there are not so many avenues for people who are personally experiencing melanoma to see the things that we think about clinically and to ask questions in an informal way outside of the very limited time that we get in exam rooms together. So we've tried to keep the presentations today succinct to factor in plenty of time for you all to be able to ask your questions. We have this group in the room, but there's also an appreciable number of people online right now who have also tuned in. They will be able to ask questions as well. So we're going to alternate between you all in the room and our online group. And we expect that other people will come and go as the day goes on because people are busy, and we respect that. And if you need to leave early for whatever reason, that's fine, because the fact is you made it here this morning and we're so happy to have you. Before I get into my presentation, I'd like to introduce to you Anne from AIM at Melanoma. Anne was one of the first people that I got introduced to when we started planning this last November. And she and also Joanne from UNM have been just steadfast partners in getting this planned today and making this successful. So she has a few housekeeping things she wants to cover before we get started. So please welcome up Anne.
Thank you. Well, I am just so delighted to be here today, and it has been a delight working with Joanne to put together our first of what I hope will be many collaborative Living with Melanoma symposiums. The University of New Mexico is very fortunate to have Dr. Savage, and I know that you guys know that. And we're excited about all the presentations that we have planned for you today. I'm going to get an opportunity later on to talk to you about AIM at Melanoma. But what I wanted to do now is explain how our question and answer periods are going to work, because we know you're going to have lots of questions. So if you have joined us here today, then if you look in the patient packet that I gave you, I got to meet most of you, you'll see that you have a pad in there. We want you to take copious notes, but also we want you to feel free to ask questions to our panelists. And we'll have two Q&A sessions, one in the middle and one at the end. So when we break for questions, if you have written down a question, if you'll hold up your question, we'll come and collect them and I'll bring them up here to Dr. Savage. And if you are joining us virtually, if you're one of our virtual viewers, welcome. We're so glad to have you. We know that we have people that are joining us via Zoom and Facebook and YouTube. If you're joining us via Zoom, then you just need to look at the bottom of your screen, and there you'll see a Q&A tab. That's where you should put your questions. And again, I'll write those down for Dr. Savage and get them to him. And then if you're joining us via YouTube or Facebook, just put your question into the comments. And again, we'll get those to Dr. Savage. Now, many of our virtual viewers were very excited about today's presentations, and they sent in questions in advance. How about that? So I'm going to hand those over to Dr. Savage now, and I'll hand the podium back to him, and we're off. Welcome and thank you for being here.
We've got an assortment of talks for you today. We've got a dermatologist, a surgeon, a clinical trialist, and also a member of our cancer care community from New Mexico Cancer Center who also helps people with melanoma journeys, who will all be presenting today. I thought I would lead this out by giving you an overview of where the state of treatment stands today for advanced melanoma. I've got some clinical data here, I've got some infographics, but I've tried to keep it brief so that we have time for questions. And as Ann said, write down anything that comes to mind as we go through this so that we can talk about it at the end. This is a picture, histology behind my text of a melanoma. This is a skin biopsy, and you can see the pigmented cells, the melanin that's produced by these tumor cells that's embedded within the tissue. This is what pathologists see, and this is kind of the first indication for a lot of patients that they may have a melanoma. This is cutaneous melanoma because you see the pigmented melanin in the tissue. Well, let's kind of level the playing field and talk about the types of melanoma that exist and what it is and how common it is, because this may not be something that somebody's gone over with you before. I've got pictures here to show you some of the anatomy of the skin. You've got melanocytes, which everybody has in their skin, even if you have a type 1 skin, which is a very pale skin, or even if you have a really dark skin, everybody has melanocytes in their skin. And this what makes this material, melanin, that provides you some degree of UV protection throughout your lifetime. Melanoma happens, cutaneous melanoma happens, when those melanocytes start dividing irregularly and just stop knowing how to stop dividing. But there's other kinds of melanoma too. This is a cartoon that shows you what an invasive melanoma starts to look like. And then I've put in a picture of an eye because this is a type of melanoma that not as many people think about, but it has some similarities to cutaneous melanoma, which is the thing that many people think about. When I talk to folks about melanoma, I think of 4 large categories of melanoma that exist. I'm going to start with the middle one. This is the one that you think about most often, a cutaneous melanoma. These often occur for people who have a fairer skin and who have had a lot of UV exposure in their lifetime. But even those are not guarantees. You can find melanomas in people with dark skin. You can find melanomas in people who haven't had a lot of sun exposure. It's very variable. We just know that there's some commonalities that about risk factors for melanoma. But then there's 3 types that many of you probably haven't heard about or thought about. There's acromelanoma. This is the kind that happens on the hands, the feet, the fingers, the toes. We don't exactly know what causes it, but it's not sun exposure related. It might be trauma related. You've got mucosal melanoma, which can occur in the sinonasal tract, the oral pharynx, anywhere throughout the digestive tract. Those are not sun exposed areas. We don't exactly know what causes that melanoma either, but we use some of the same treatments for it that we use for cutaneous melanoma. And then the most rare is a uveal melanoma, which occurs at the back of the eye. And this is showing you a pigmented area at the back of the eye. And this is treated in a very different way from cutaneous melanoma, and the surveillance strategy is different for it. But the common thread is that I have the opportunity to meet people going through journeys with all 4 of these here at the Cancer Center. And we have adapted some of the treatments that we use for cutaneous melanoma to these other types, sometimes successfully, sometimes less so. But a lot of what I'm going to talk about with immunotherapy now is going to be very relatable to a lot of these types. So 4 main types of melanoma. Here are the 2025 numbers from the SEER data set and from the American Cancer Society. So in the United States, 2 million people will have a new cancer diagnosis this year based on 2025 data. And that's a death rate of about 618,000 people. In that, there's 112,000 new cases of melanoma that occurred in 2025. So we'd expect something similar in 2026. And the death rate is much lower than cancers in general. So 618,000 people die of cancer, but only 8,500 people die of melanoma. And right now we have a 94% 5-year survival rate, which is incredible because when I started medical school, the survival rate for melanomas of all types was not that good. And I'm going to talk a little bit about the things that changed to make this so much better. So 112,000 new cases, 8,500 deaths with a 94% 5-year survival rate, which is the 4th highest of any cancer, which is incredible. So there's a lot of people who get melanoma, but there's a lot of people who survive melanoma. And that's why we called this a survivorship symposium, because it is a scary thing to go through, but we are seeing more and more survivors of this who get to live natural lifespans, and that's incredible. Melanoma stacks up this way against the other common types. So breast cancer, prostate, lung, and colorectal are our most common kinds of cancers. That probably represents 70 to 80% of the kinds of cancers that are seen here at the Cancer Center. But melanoma is number 5 right there. So there's a lot of people who end up for a lot of reasons with melanomas. But melanoma consistently in 2026 has a lower death rate than other types. You know, lung cancer, even though improvements have been marked in lung cancer treatment, there's still a lot of people who do not survive their journey with lung cancer, but that is quite the opposite with melanoma. And that's why we wanted to share these data with all of you to provide some hope that whatever you're going through right now is going to allow you to be one of those survivors. So I want to go back in time and tell you what got me really excited about melanoma care, and that's immunotherapy. This really changed the game for stage 3 and stage 4 melanoma. Stage 1 melanomas are very tiny melanomas on the skin, if it's cutaneous. Stage 2 are a little bit deeper. But stage 3 means they travel to a lymph node, the cells travel to a lymph node. Stage 4 means the cells are somewhere else in the body. It's really stage 3 and 4 that I'm going to spend the rest of this talk talking about, because these are the situations where we most commonly use immunotherapy. This really snazzy graphic shows you a T cell interacting with some antigens on a nasty melanoma cell. And what I tell people all the time is that when you get these infusions here at the Cancer Center or wherever it is you get treatment, the infusions themselves aren't the things that kill the melanoma. The infusions or the injections activate a person's immune system so that the immune system can attack the melanoma. And that was really the game changer with melanoma care. There was a hypothesis 30 years ago that we could somehow turn the immune system on to do this, but it took a lot of clever research to make it happen. When I think about this journey, I go back to this article from '96. If you look at the lead author, it's Nobel laureate James Allison. I'm from Texas. He's also from Texas. And he's now at MD Anderson Cancer Center. And when this research was published, it was actually hard for them to publish it, because what they did was they took a drug that they had developed against the CTLA4 protein, which is on T cells, and they injected that drug into mice, and the tumors just stopped growing. So they made some injections, and the control group, the tumors just took off. The volume of the tumors got bigger. But in the groups treated with either of these CTLA4 groups, the tumors just stopped. And when they tried to publish this in the first few journals, they just didn't believe the science, because they said that's not possible. That's not a paradigm that we're familiar with. We don't really have trust in the validity of the data. So they had to do a lot of other things, surrogate experiments, to prove this. And the journal Science ultimately published it. And this really changed the world. It changed the world for melanoma, changed the world for cancer, because what followed after this really has made the survival opportunity a lot better for people with melanoma. Then the New England Journal in 2010, and this just kind of shows you how slow science moves sometimes. This was '96. That was a mouse study. And then this was a clinical study in the New England Journal in 2010. They used the same drug, ipilimumab, which we now is branded as Yervoy. We use it for people with melanoma all the time. And people who received the Yervoy treatment had an improvement in their overall survival. And this was one of the first times in melanoma care that a drug was shown to improve survival for people with stage 3 and stage 4 melanoma, which was incredible. It was not too long after this that all of the commonly used drugs pembrolizumab, nivolumab, ipilimumab became commonplace in the treatment of melanoma. That's my phone. We'll silence it. So after the Science article was published, after the New England Journal article was published, the Nobel Prize was awarded to two different investigators, Jim Allison from Texas and Tsuku Hanjo from Japan for their discoveries. Dr. Allison for Yervoy and Dr. Hanjo for what we now call Opdivo. And for those of you in this room, many have had experience with these two drugs. I mean, that's our frontline treatment nowadays for stage 4 melanoma. In some cases, we use them for stage 3 melanoma. These things were all happening when I was going through my medical education journey. And so when I started working with my first melanoma mentor, I got really excited about the opportunities to help people with these two, with the drugs that were available for immunotherapy stimulation for melanoma. I've got a couple of striking photos to share with you. These are PET scans. And on the left side of each frame is a person who has widespread metastatic melanoma. When I started medical school, somebody who had a scan in frame A on either of these would have had a very short lifespan following that. But now we have a lot of treatments for people with advanced melanoma. If you look at the left frame, this person got treated with a BRAF targeted drug. 50% or so of cutaneous melanomas have BRAF mutations. We test for it in everybody that gets a new melanoma diagnosis. And by taking oral pills every day, the person in this picture was able to go from this to this, extensive disease to almost no detectable disease. Well, that's one strategy we use commonly for treating melanoma now. On the right side, you have somebody, again, with extensive melanoma, and this person was treated with anti-PD-1 therapy, which is an immunotherapy, and the subsequent PET scan shows no significant detectable disease. This is the promise and opportunity of immunotherapy, particularly for melanoma, but after this really changed the world for melanoma, people around the world started looking for ways to apply immunotherapy to other cancer types. And there's some really great examples in breast cancer, colon cancer, lung cancer, where we use immunotherapy all the time to improve people's survival opportunities. Let's talk about these two kinds of treatment. So the first are what are called checkpoint inhibitors. Well, why do they call it that? Your immune system by nature is programmed to not attack your body. People who have irregular immune systems have what are called autoimmune diseases. They can have rheumatoid arthritis or inflammatory bowel disease. And that's when their immune system, without any drug or provocation, attacks their own body. Well, these investigators who won the Nobel Prize in 2018 for immunotherapy had a hypothesis that there were some key proteins on T cells that turned the immune system off and kept it from recognizing your body. And their hypothesis was if we can deactivate those proteins, we can allow the immune system to attack cancer cells. And those proteins are called checkpoint proteins. So here you've got a T cell, part of your immune system, and it recognizes a melanoma antigen on a tumor cell, but then it has these co-stimulatory proteins. Or here you have the PD-1, PD-L1 co-stimulatory proteins. When these are engaging the T cell, it tells the T cell, don't attack this. This is the human body. Don't attack this. But the special sauce to immunotherapy is you have a checkpoint inhibitor, an antibody, that interferes with this interaction between PD-L1 and PD-1, and that allows an activated T cell to destroy a melanoma cell, essentially making your own immune system the treatment. Now, it doesn't always work on target. We manage people with immune-related adverse events very regularly because when you turn off this regulatory process for T cells, sometimes those T cells can attack your skin, your joints, your lungs, your digestive tract, your thyroid gland, and it can cause them to stop working. But in a lot of people's opinion, those are manageable side effects and side effects people are willing to tolerate, knowing that they can have the opportunity to get their melanoma into remission. So this is one strategy that we use for advanced melanoma. The other one are pills, BRAF drugs. And BRAF is part of a bigger growth pathway called the MAP kinase pathway. In all of our cells in our body, MAP kinase is a common growth pathway. But we know that in about half of melanomas, the cells will have a BRAF mutation, V600E being the most common. Well, there's an array of drugs, vemurafenib, dabrafenib, encorafenib, that can target a BRAF mutated protein in a melanoma cell, and it can have that striking response that you saw in those PET scans where the melanoma essentially disappears. The one problem with this kind of strategy is that sometimes the response is not as durable or long-lasting as the immunotherapy is, and I'm going to get to that in a minute. There was a study called the DreamSeq trial that was published in 2022. You know, we had these amazing treatments, BRAF drugs, checkpoint inhibitors, and for a while, people didn't know which they should be using first because you saw those two PET scans where both had amazing responses. So what should we be doing first? Some people would prefer pill-based oral therapy as opposed to an infusion or injection because it fits their lifestyle better. They don't have to be here every 3 or 4 weeks to get a treatment. So some people were favoring that for that reason, but we didn't have empirical data to show which was better until this study happened. So what you see on the y-axis is survival. And early on, whether they were treated with the pills, which is the red line, or immunotherapy, which is the blue line, people do great. Their survival's good. They have really great treatment responses. But at some point around a year to year and a half, there's this inflection point where people treated with the red line sometimes start to do worse. People treated with immunotherapy, though, have a plateauing of the survival curve where each of these little dashes indicate a life. And this, I think, for a lot of people in the US and worldwide, changed their treatment approach where they said, we want to get people on immunotherapy as soon as we possibly can. But sometimes that's not possible right away. People sometimes come to us and they're very symptomatic and they need to be on a targeted medication first, and that's totally fine. I think what a lot of people settled on after the DreamSeq data was, even if somebody has to be started on pills first, as soon as practical, we try to switch to immunotherapy. Now, sometimes that's just not a viable plan. People have side effects, real significant side effects from immunotherapy. And so there's going to be people in this room who maybe tried immunotherapy and for a variety of reasons it wasn't working or they had big side effects, and that happens. And when that happens, we go back to the pills because they do work. And then there's other options beyond that, and I'm going to share a little teaser about that with you today. And then Dr. Mosier, who's going to present later, is going to give you a little bit more detail about it. But here's the really good news. This is data from a New England Journal article in 2024. And this is 10-year survival data for people treated with Yervoy and Opdivo, also called ipilimumab and nivolumab. And what you're seeing is 50% survival at over 10 years. And that's why you can go to symposia like this and you can meet people who had stage 4 melanoma who 10 years later are able to come to a symposium because they're a survivor of melanoma because of immunotherapy. This was not the case when I started my medical education. And when I saw these data come out 2 years ago, it was just so exciting to think that immunotherapy has just totally changed the landscape for the better for people with melanoma. I mentioned ipilimumab and nivolumab, but there's one new drug that got an FDA approval after 2022, and that's relatlimab. So we have 3 checkpoint targets. There's PD-1, PD-L1, CTLA-4, but then there's also LAG-3, which is another protein on T cells. And this is another good way to treat stage 4 melanoma. So we have a choice these days. We can either use 2 drugs, relatlimab, nivolumab for stage 4 melanoma, or we can use ipilimumab, nivolumab for melanoma. And the outcomes and the long-term survival benefit and the prospective impact on progression is equivalent for the 2 drugs. So it's nice to have options when you're facing a new diagnosis of advanced melanoma. So when I think about this, these are the options that I think about for advanced melanoma. So for stage 2 melanoma, I would say for most people, they get surgery and then surveillance, and that is the most common treatment for people with stage 2 melanoma. There are FDA approvals for pembrolizumab and nivolumab for stage 2 melanomas, but I think those are case-by-case bases because 25% of people can have side effects from immunotherapy, and that's not a decision that me or other people here at the Cancer Center make lightly. If somebody can be cured through surgery, that's the preferred thing to do. For people with stage 3 melanoma, we use immunotherapy quite regularly now, and I'm going to say a few things about that. And then for stage 4 melanoma, you have many options. So there's the LAG-3 PD-1 option. There's tumor infiltrating lymphocytes, which we're going to hear a presentation about later today. There's a bispecific specifically for uveal melanoma. And then there's a variety of ongoing clinical trials with what are called T-cell receptor modified stem cells. So one of the newest treatments around for advanced melanoma, and you're going to hear a full talk about this later, is lifileucel or TIL. And this is a cellular therapy. This is where we use the body's own cells to treat melanoma. Checkpoint inhibitors turn off a protein and keep the cells in the body to treat the melanoma. Lifileucel, you collect the cells from the body, you expand them in a lab, and you put those cells back in the body to treat the melanoma. I've got a little infographic on it, but you're going to hear a whole presentation about this later today. So the tumor is cut out, cells are removed from the tumor, the cells are expanded in a lab. The person comes back to the hospital and they first have to get some chemotherapy to knock down the other cells in their body. They get the cells back. The cells then get activated by giving them interleukin-2, and then they do possibly what this cartoon shows, which is they attack the melanoma cell in a most aggressive way, as this graphic describes. This is an FDA-approved treatment now for people with treatment refractory stage 4 melanoma, but there's some caveats to it. It works best in people with cutaneous melanoma, and you have to get chemotherapy in order to get it. So a lot of times there's an age threshold beyond which you can't do it because there's an age threshold where it's not safe to give really intensive chemotherapy before you give cells back to a person. So this is one option for an advanced melanoma that you're going to hear a talk about later today. These were the data from that study. This is what's called a waterfall plot. Whenever you see bars that go negative or down on a waterfall plot, the bottom line is that's good news. So here you see 2 people with complete responses and a lot of people with partial responses. Every one of these bars represents a human life. And what was incredible about these data is these are all people who were heavily pretreated. They had had maybe a BRAF drug, maybe immunotherapy, and then the disease progressed. So people said, what else can we do? And they did lifileucel. And this is changes from baseline in their disease burden. Now look at this waterfall plot. The waterfall, it's like Niagara Falls because you've got so many bars that are negative. Look at all these complete responses here. And these, again, are in people that were heavily pretreated with other drugs for melanoma. And then the last one is what overall survival looks like. And if you look all the way out to almost 5 years, you've got a 35 to 40% overall survival, which is really unheard of when you think that immunotherapy changed the game, but some people have progression on immunotherapy, and those people 2 or 3 years ago would have passed away. And now we have a cellular therapy that can salvage that situation and allow about a third of them to continue living. To me, that's incredible. Lifileucel, we don't yet have in New Mexico, but we're going to have a presentation from a center in Phoenix that does it later today. I send people there regularly to discuss this treatment with them, and we're working on getting it in New Mexico. So for those of you that may need it in the future, it's possible that we'll have it here just in time should you need it. Remember back to that first presentation or the first slide at the beginning of the presentation, I said we had cutaneous melanoma, acral melanoma, mucosal melanoma, and then this very rare subtype called uveal melanoma. With uveal melanoma, we know that there's a blood type, HLA-A0201, that when cancer cells have it, allows them to be attacked by T cells. But in order for that attack to happen, we need a drug or an antibody that will connect the T cell to the cancer cell. And that drug or that antibody is called tebentafusp, which is a once-a-week injection. This is another immunotherapy approach for uveal or eye melanoma that totally changed the game, especially for people whose tumor is HLA-A0201 positive. Because before this drug got approved, we really didn't have a lot of effective treatments for people with uveal melanoma. So we have cellular therapy, bispecific therapy, checkpoint therapy, all immunotherapy approaches for melanoma. And this is the data from 2023, specifically with tebentafusp, showing a statistically significant survival benefit. Whenever the top curve has a lot of daylight between the bottom curve, that means that's good. And what you see is the percentage of patients surviving because they receive this injection. So not everybody with uveal melanoma needs this. Many people are treated with radiation or surgery and they have a cure. But for people who have recurrence at some point, it's really nice to know that they have a treatment option available. The last thing I want to say is I want to go back to stage 3 melanoma. If you looked back about 5 years ago, people who had stage 3 melanoma, they had a surgery, a wide local excision surgery to remove their melanoma. They also had a sentinel node biopsy to see if any nodes were involved with melanoma. And they might have a complete node dissection in some cases where they take out all the lymph nodes near where that melanoma occurred. As immunotherapy has been introduced to stage 3 melanoma, it has also changed the whole paradigm in how we treat stage 3 melanoma. About 5 or 6 years ago, you had the SWOG 1801 study that demonstrated if you gave a person neoadjuvant pembrolizumab, neoadjuvant means you give the drug before they have surgery, that you could improve a person's survival. And for several years, this became the treatment paradigm. So a person has a melanoma diagnosis, they have melanoma in lymph nodes. Before a surgeon ever did anything to them, that person would come and get a month and a half of treatment with pembrolizumab. And then they would have surgery to remove the melanoma and the lymph nodes. And there's a big gap or big space of daylight between these two curves, showing that the event-free survival, the odds of having a recurrence of melanoma went down appreciably if people got a little bit of immunotherapy before they had surgery. So for many years, this was the paradigm. But then if one drug works well, maybe 2 drugs works better. And this trial, Nadina, which was kind of unveiled at ASCO 2 years ago, that's our major cancer conference, they asked the question, could we give somebody ipilimumab and nivolumab, so the 2 common drugs used for stage 4 melanoma, could we give those to people with stage 3 melanoma and get an even better response than giving them 1 drug before surgery? So people either got 2 drugs or they got 1 drug, they had surgery. Now, the really interesting thing about this study was people who had a major pathologic response, meaning no melanoma was detected at the time of surgery because of 6 weeks of drug treatment, those people didn't need to continue immunotherapy. That saves them time for coming to an infusion center, and it saves the health system upwards of $250,000. I mean, it's really a staggering number. And here's what the data showed. When somebody got 2 treatments with ipilimumab and nivolumab before surgery, there was almost a 30% difference in event-free survival. So this changed the whole paradigm again. Rather than giving people 1 drug before surgery, we started giving 2 drugs before surgery. And this is what we do as standard of care now for people with stage 3 melanoma. The other thing is that 60% of people who get immunotherapy before surgery don't need it after surgery. And that's a really big lifestyle factor because I recognize that it is a lot to ask somebody to sign up for a year of treatment of any kind at a cancer center. I mean, it's a huge cost. It's a huge burden to come to a cancer center every 3 weeks, 4 weeks, 6 weeks. And so when we had a paradigm that allowed us to not have to make people do that 60% of the time with stage 3 melanoma, that was huge in a very positive way. I'm going to say one more thing about treatments that are currently in study, and that's T-cell receptor directed therapy. So we've talked about how checkpoints can turn T cells off to allow them to recognize melanoma. We've talked about taking cells out of your body, growing them in a dish, and putting them back in to attack the melanoma. But there are a variety of clinical trials happening nationally and internationally right now with a different kind of cellular therapy called TCR therapy. Here, you take a T cell out of a person's body, you insert a very specific receptor, usually with a virus, into those cells. You grow the cells in a dish, and then you put those cells back into the person's body. And that receptor that you add allows the T cell to recognize the melanoma even better than it would have natively. This is a strategy we use all the time now with myeloma and other blood-based cancers. And there's investigators saying, well, if these things work really well for blood-based cancers, can we adapt them to work really well with melanoma? And I hope the answer is yes, because you all have, in a variety of ways, had experience with the current approved treatments, the targeted therapy, the immunotherapy. But I think as a person who treats people with melanoma, as people who have survived melanoma, we're all thinking about, well, what's the next step? What's the next option that I have should my melanoma come back or progress? And I just want to say that there's a lot of hope. There's a lot of opportunities in the pipeline for those situations. So just to summarize, we have talked about stage 2 melanoma. Largely surgery is how we treat it. Sometimes immunotherapy, but mostly surgery. We've talked about stage 3 melanoma, which we have the option now of treating with immunotherapy before surgery. That's neoadjuvant. And then there's a lot of things we can do now for stage 4 melanoma. We have the relatlimab-nivolumab combination. We have the ipilimumab-nivolumab combination. We have TIL. We have bispecifics for metastatic uveal melanoma. And then ongoing clinical trials are happening with the T cell receptor modified T cells. So I want to thank you all again for being here. For our online crowd especially, I've got my email address. For the crowd in the room, I've got my email address. I welcome you to reach out if you have questions, if you are an advocate, if you're raising money for melanoma research, if you're working on a research project and you wonder, could people in New Mexico help you with that? Could the patient population we have help you with that? I'm always eager to interact. So thank you very much. Okay, just wait. Okay. They go to the next person. Okay. Let's see, Dr. Matsumoto, right there. Great. Well, I want to introduce you to our next presenter. This is Dr. Matsumoto, who is a dermatologist and also a Mohs surgeon. And he sees a lot of our patients who have melanoma or other skin cancers. And he's going to talk specifically about Mohs, a very specific kind of surgery for melanoma. So please welcome Dr. Matsumoto.
Morning, everybody. So I've been tasked with talking about Mohs for melanoma. It's a very large topic, but I'm going to try to hit on some of the high points for you all. So I have no financial interests to disclose. These are my acknowledgements. Okay, so today I want to briefly just talk about Mohs surgery and then Mohs for melanoma. I'll review the indications and benefits and sort of challenges of Mohs for melanoma, and then sort of describe some of the diagnostic criteria you use to look at these melanomas, and then show you guys some images of what I see under the microscope sometimes too. So just some background on melanoma in situ, Mohs for melanoma. So for most of the Mohs for melanoma, the ones I take care of are in situ. So stage 0 or T1A, which is stage 1. When it's beyond that, typically things are needed, such as a sentinel lymph node biopsy or seeing Dr. Savage. So this is just for early melanomas in general. So the standard of care for these early melanomas and yeah, most localized malignant melanomas is surgical removal with clear margins. Lentigo maligna subtypes of melanoma are both in situ and early invasive. The ones I deal with most have extensive subclinical spread. And so what I mean by that is if you look at a melanoma, you look at its pigment, you think you can identify its boundaries, but if you look at it microscopically, there are tumor cells sort of infiltrating normal skin. So it's hard to identify where it's starting and where it's stopping. This leads to wider than anticipated margins required for clearance and sort of an asymmetric growth pattern. Some background studies on this. It's been identified that just taking a 5 mm margin around these early melanomas is often inadequate because of the subclinical spread. It's been identified in about 12 to 71% of cases. These have been shown to be more prevalent in areas on the head and neck, acral limbs or pretibial legs, recurrent lesions or larger lesions, or patients over the age or equal to 60. So very common thing I encounter. A recent study of both early invasive lentigo maligna and malignant melanoma in situ is to achieve 97% clearance. A 12 mm margin was needed on the head and neck, and a 9 mm margin was needed on the trunk and extremities. And this even happened on sun-protected skin. I mean, often the melanomas you see are at the head and neck, and there's a lot of sun damage, so it can be hard to identify them. But even on the areas that are sun-protected, and it appears that the melanoma is very confined and easy to identify, there's a significant amount of subclinical spread. So with that in mind, Mohs is a great option for sort of mapping out how far this tumor is going. I get a lot of referrals from head and neck where they excise an invasive melanoma. There's in situ positive on the periphery. They've done an additional procedure. It's still positive. It's very tedious to go back to the OR and have multiple procedures. So what I do, it's all local anesthesia. The patient, you're awake. It's a cost-effective and easy procedure and done rather quickly in that respect. So our appropriate use criteria has deemed Mohs as appropriate for treatment of all MIS and lentigo maligna, with the exception of primary lesions on the trunk or extremities, where it's been deemed uncertain appropriateness. Now, for malignant melanoma, it's a controversial topic, but I would say outside of anything beyond T1A, Mohs for melanoma is not really advocated for or recommended at this time. So kind of going back to this, Mohs micrographic surgery is an alternative to wide local excision for melanoma in situ and early melanomas, T1A melanomas. Predetermined margins, this is because predetermined margins may be ineffective in some areas and excessive in other areas at the same location. The Mohs method, which I'll touch on in a second, gives you 100% margin control with tissue sparing. It's cost effective and same-day reconstruction, and with the use of melanocytic-specific immunohistochemical stains, such as MART1, it aids in reviewing these frozen sections that adds to stronger cure rates. And they've been shown that cure rates for Mohs is comparable to wide local excision and potentially more favorable outcomes in these early melanomas. Recurrence rates have been reported as low as less than 0.5%. So going back to Mohs surgery, hopefully you're somewhat familiar, but I'll kind of go over this as well. But it's a technique of tumor removal that I specialize in. Most of my clinic is doing these procedures where the tissue is processed in an outpatient facility with frozen sections on FOSS. And I'll touch on what that is in a second too. The patient is brought in, the tumor is marked, everything is anesthetized with local anesthesia, nerve blocks, and anti-anxiolytics, so the patient is comfortable. And then the tumor is removed and we check it in our lab. We do this 100% margin evaluation. Because of this, it offers the highest cure rate for the majority of our common skin malignancies. It's tissue sparing, as I mentioned, because I don't have to take an incredibly large margin to start. I can take it very small. If there's any residual tumor, it's mapped out in such a way where you can go back in just a certain area to achieve highest clearance and most tissue sparing. After things are clear, the area is reconstructed same day in the office. So indications, it's multiple and case by case, but in general, it's any of these common skin malignancies on the head and neck or larger ones off of the head and neck or higher risk tumors anywhere. Additionally, I do some rare tumors such as AFX, DFSP, EMPD, sebaceous carcinoma, and MAC. But today, mostly going to talk about melanoma in situ, as I mentioned. So the procedure itself, this is a patient with a BCC on the left upper forehead. We mark the area, we anesthetize it, we clean it sterilely. The tumor itself is debulked with a curette. This helps define the margins and gives me an idea of how far to start in terms of like how deep and how wide to go in this tumor. Afterwards, about 1 millimeter or 2 margin around the tumor on the periphery and underneath it is taken. Again, this is completely anesthetized, so the patient doesn't feel anything. I put hatches on the tumor specimen on the patient, and we gross this in a way so I can identify the hatch under the microscope. And so say there's a little tumor left at the 3 o'clock. I can pinpoint exactly where that is. I see there's a 3 o'clock hatch that was placed on the initial excision that's on the patient. And so I don't need to take a really wide local around the whole thing again. I can just take a small crescent where it's positive. This is the removal of the base of this tumor. And then at the end of it, I gross everything myself. So the tumor is removed and it is mapped and inked. And all this is processed in our lab. The best analogy I can give for Mohs is if you think about like a Reese's cup and the tumor and the chocolate, it's all like the tumor, that's all removed and excised out. That wrapper itself is the Mohs layer I'm taking, sort of this margin around it. That is flattened and cut in a horizontal fashion. They call that en face, as opposed to standard bread loafing, which is done vertically up and down. Because of that, bread loafing only gets little fractions of the margin periodically around the tumor. But with Mohs, if done correctly, you get 100% of the margin evaluation. That's why it leads to those higher cure rates. This is just a table identifying that Mohs generally has higher cure rates, a lot to just a little bit more than any other treatment modality for our common skin cancers that I deal with, which would be BCCs, SCCs, and early melanomas. This is a Mohs section. This is one that's been cut in half, but this just gives you an idea of what I look at underneath the microscope. The ink there, the blue and the red, that's the depth, and those correspond to hatches. So I can see the entire margin, I can see the entire depth. If there's any tumor, I can identify where exactly it is. That ink corresponds to a location on the patient, and so I know exactly where to go back for. The advantages of Mohs surgery, it's superior cure rate through that 100% margin evaluation. There's the maximal tissue conservation. Because it's all done outpatient, it avoids expense and complications of hospitalization and general anesthesia. The disadvantages is it's very specialized. You know, it takes years to train techs and nurses properly to get them. We have a really great team here at UNM, but it took, you know, about 4 years to kind of like get that team because you have to train them so well in it. If the procedure goes many stages or like, you know, extra stages to get the tumor, it can become quite prolonged and tedious for the patient. So always have to warn my patients that is a possibility, but we do our best to keep things as streamlined as possible. If it's inappropriate utilized, especially with private equity and things upcoming, it can be very inappropriately utilized. It can significantly increase the cost of skin cancer treatment. And it's unable to be utilized for discontiguous or metastatic tumors. So back to Mohs for melanoma. One of the initial challenges with Mohs and melanoma is it's very difficult to distinguish melanocytes from keratinocytes. They look almost identical if the sections are not pristine. Usually things can be complicated by freeze artifacts, folding, uneven staining, all just are normal things that pop up in normal Mohs sections makes really interpreting melanomas difficult. So because of that, there's been the advent of immunostains. Many out there, this is a MART1 immunostain, and these highlight melanocytes with a chromogen visible on light microscopy. It allows for detection of melanocytes as accurately as permanent section immunostains, and it can serve as an aid to increase the accuracy of margin assessment. So looking at these sections, it's very crisp, it's very easy to interpret. It makes Mohs and melanoma much more accessible to the average Mohs surgeon in the US. This photo didn't come out great, but basically on the right, it's just demonstrating this is a melanoma. And if you're just looking at this with permanence without the aid of stains, it's very difficult sometimes to determine if it's positive or not. But if you have the MART1, you look at that and you say, oh, that's very clearly positive. It really helps. Many immunostains out there, MART1, HMB45, S100, MITF, SOX10. I would say 95% of the Mohs surgeons in the US use a MART1 immunostain of some kind. So MART1 or melanoma immunostain, it's a melanoma-associated antigen recognized by T cells. It's specific and sensitive for frozen section margin evaluation, crisp and easy to interpret. And unlike S100, does not label nerves or skin appendages or Langerhans cells that might skew your analysis. Sometimes there's a gray zone in interpreting these, so we do have a diagnostic criteria for our melanoma in situs. These are things we look for. If we're not entirely certain if this is just a patient with a lot of sun damage and they have a lot of melanocytes, which can happen in sun damaged skin, versus an early melanoma in situ, they have to fit these criteria. I won't touch on all of them. I'll show you some images of them here in a second. This is normal skin, and this just highlights even in people with normal skin with a MART1 stain, there's going to be some level of positivity. Usually there's 1 melanocyte to 10 keratinocytes, so there's some background melanocytes in everybody. It's just the nuance is differentiating when that becomes too much. This is a positive MART1 immunostain. On the left, this is permanent sections, and on the right, this is the MART1, just really, really highlighting how easy it is to interpret. There are things we look for in our stains. So this is vertical stacking of melanocytes. As you can see, each one of those melanocytes is on top of each other. It's atypical. That usually cues in for a early melanoma in situ. Nesting, this is when melanocytes start to cluster at the basement membrane of the skin, another worrisome sign for melanoma in situ. And this is confluence. This is where melanocytes start to become in direct contact with each other in the basement membrane. It gets kind of jumbled, hard to see. Another positive melanoma in situ characteristic. And this is just a nice image of a MART1 stain positive for melanoma in situ. So I briefly touch on some of the surgical execution for this. For all of our melanomas that I see, if the biopsy report comes back and it says it's been transected, the first step always is to rebiopsy that lesion to make sure it is the proper stage. Because if it's an inadequate stage and it's a stage 3 or something like that, then they need to see Dr. Savage and head and neck surgery before they see me, because that will usually require additional workup such as sentinel lymph node biopsy, imaging. They might be immunotherapy candidates. So always, if I see a biopsy report that's been transected, I will rebiopsy it. Next, and if that's been taken care of, it's not been transected, it's of the appropriate stage to treat for Mohs surgery, we mark that out. And we use something called a Woods lamp here. Basically, it's like a black light, more or less. And you turn off the lights, you turn that on, and it really highlights where that melanoma is starting and stopping more accurately. Obviously, there could be more subclinical spread, but that's the first thing to do. Next thing we'll do after we're starting the procedure is we'll debulk that tumor. So that tumor that I've marked out with the Woods lamp, I essentially will rebiopsy at that. And the reason being is when we do these Mohs sections, we're just focusing on the peripheral and deep margins. It's difficult to identify the depth or the stage of that tumor. So the debulk is essentially rebiopsying the whole thing. Because if the tumor was only partially biopsied, there could be a pocket of more invasive melanoma that would change the staging and the workup. So we sort of do this to make sure we're not missing anything. And this is just a table in our literature demonstrating that if you do send these debulks, a non-insignificant fraction, this column on the right, far right, demonstrates that you get upstaged in a 7 to a 6. Well, I don't think that's true, but probably about 5. I usually tell patients 5 to 10% of cases it will get upstaged. So we always send that. And this is just a representative of that. So the tumor itself, we debulk that, and then about 5 to 6 millimeters around that tumor, that's our Mohs layer in general. This is just another graphic of that. We mark that tumor out, we debulk it, we take the Mohs layer around it. Okay, so for our Mohs layer, our first Mohs layer around that, the initial margins are variable. It's somewhere in the 3 to 6 millimeter range. It's wider on areas that are not cosmetically sensitive, say in like the neck or something like that, or if there's like extensive background damage where it's really difficult to identify the boundaries. But it's more narrow if there's not a lot of residual lesion post-biopsy, or it's in a very cosmetically sensitive area such as the eyelid, nasal tip, something like that. But usually I try to never make them less than 3 millimeters. So the first peripheral margin, it's 5 to 6 millimeters around it in general for the in situ lesions. For the early invasive ones, about 5 to 10. The deep margin per our NCCN guidelines for the in situ lesions, I try to keep that into mid-fat depth. But if it's melanoma, it needs to go down to fascia, or invasive melanoma, it needs to go down to fascia for depth. Subsequent layers, it really depends on what the pathology report comes back as. If there's a lot of melanoma, it's aggressive melanoma, I will go wider on that additional layer. Whereas if it's sort of, they'll say like a trailing edge of a melanoma, then we can go more narrow. So there's a laboratory protocol for all these melanomas in general. You do your standard H&E, you do your MART1, there's positive and negative controls to compare all of these things. There's 2 protocols out there. There's a common 1 hour long protocol. That's what I was trained on in my fellowship. It's the highest quality. And then there's the rapid 19-minute protocol. It's more accessible. It's actually the only one we have here in New Mexico right now. But anecdotally speaking, I feel the quality is not fantastic. This is the 1 hour protocol. There's excellent literature out there. The only downside of this is the equipment is quite expensive. It ranges from $200,000 to $300,000 to get the proper equipment. But there's great evidence for it, and there's good literature on optimizing everything. So the slides come out with high quality. So currently at UNM, I attempted the quick scan here. The personally didn't like the quality. The plan is for purchasing of this 1 hour protocol equipment upon the hiring of our second most faculty, which actually we have someone who's signed on for tentative summer 2027. This will coincide with a Mohs micrographic surgery fellowship, which I've been trying to start for a while. So currently the process is somewhat similar. This is sort of a happy medium, I say. It's called slow-mos. So tissue is processed the same way I just outlined for you in that Mohs method. I remove it, I gross it, I ink it. The only difference is I send this to formalin to Tricor, where they'll prime stain it, and then they expedite it to get it read within about a day, sometimes a day and a half. The main benefit of this right now is there's a consensus conference with all parties involved at the derm paths meet where we sort of review the slides and can kind of come up with a consensus on what's positive and what's negative. For that reason, I find it very helpful. But the plan in the future for UNM to better serve the state and our patients is to get that same day 1 hour protocol equipment. And that is it. Thank you. Yep.
Well, you just heard about one surgical strategy for non-invasive or very early stage melanoma. Some melanomas, though, are more advanced when they're found, and they need the help of a surgical oncologist, somebody who can take even bigger margins from any site on the body. And the standard before we had immunotherapy was to just take really, really wide margins and really just hope that the melanoma didn't escape those margins. Things have changed, as I was alluding to, with all the ways we can treat melanoma now, where we can sometimes take smaller margins because we know we have other ways using the immune system to take care of melanoma. Our next presenter is Dr. Ridgway, and he's a surgical oncologist in the community at the Lovelace Health System. There's people in this room who have met Dr. Ridgway, and he's been a part of their care. And I work with him a lot. He'll send patients he has done surgery for over to the cancer center for other parts of their care. And I thought it would be really great to have not just UNM team members present at this, but to have other people in the community present. Dr. Ridgway had a conflict where he couldn't be here in person, so earlier this week he recorded this, and you all in the room and also online can pose questions, and to the best we can, we'll try to answer it, and if we can't get you an answer, we'll get it to Dr. Ridgway and get you an answer after the conference. So I'm going to start his recording.
Good morning, everyone. Sorry I could not be here in person with you, but I'm very excited to participate in this seminar. I think it's important information, and there's a lot of exciting things coming out in melanoma. I'm a surgeon at Lovelace Women's Hospital, and today I'll be talking about melanoma reconstruction. All forms of melanoma require surgery to correct it, but sometimes the surgery varies in the amount of tissue that's removed. So it requires reconstructive techniques to put the tissues back together for function. So our objective today is to help you learn how a surgeon makes decisions about surgical strategies, because not all patients require the same surgery, and as you'll see in the other presentations, they don't require the same therapy. So, surprise, I have a little quiz for you participants, just to help you focus on some important issues that we'll be talking about. The first question, and just think about it, is what two factors determine the surgical procedure for melanoma? And then the second question is, what type of flap can be confusing for our colleagues in radiology? So we can move on now. So as you're all aware, and it's going to be talked about also this morning, melanoma comes in different stages. If you look to your left on that illustration, you see a very early melanoma, just barely in the epidermis, and it's not down into the functional elements of skin. That's called the dermis. But as you see, as the melanoma continues to grow, it grows down more deeply into the skin. Then way over on your right hand, you see an advanced stage melanoma. And if you look down at the bottom of the picture, you see that it's touching the blood vessels and lymphatic vessels and actually getting into the fatty tissue that underlies the skin. So the deeper a melanoma goes, the higher a chance it has of getting involved with lymphatic channels or blood vessels. So the most important thing to know about a melanoma when you're planning therapy is its depth of invasion. And if you see, there's a hint. This is one of the 2 factors that determines surgical strategy. So you've already got one answer this morning. Deeper melanomas require larger amounts of tissue to be removed. Earlier melanomas can be safely removed and controlled with just a 1 centimeter margin. Thicker melanomas, those that are over 1 millimeter in thickness into the skin, require 2 centimeter margins. So if you may remember from your high school geometry, 2.5 centimeter margins or 2.5 centimeters is an inch. So we have to go almost an inch all the way around the melanoma when they get thicker. So as you can imagine, that's quite a bit of tissue that needs to be removed. And that's on the surface of the skin. So the next slide will show the depth of invasion there. It was not captured very well in this illustration, but there's skin and the underlying fat below the skin. Even thin people have fat below their skin. That also contains lymphatic channels and blood vessels that need to be removed. So invasive melanomas require excision of skin and the subcutaneous fat all the way down to the connective tissue that wraps around the muscle. So that's the depth of the excision. So we talked about how wide to go, and then this slide shows us how deep down we need to go. So another consideration is the anatomy. As you can imagine, if a melanoma occurs on a person's chest, abdomen, or back, there's quite a bit of skin that's available to pull together for the reconstruction. Certain arrows are quite thin, as you can see in our illustration. For example, the forearms and calves, or wrists and ankles. The other thing that's important to know is melanoma can occur on any part of the body that has skin. So it's not just sun-exposed areas like some other forms of cancer. So melanoma surgery involves surgery from the scalp all the way down to the soles of the feet, potentially. So that also determines how much surrounding tissue is available for the reconstruction. So, and you see, I've given you another hint there. Anatomy is the other factor that helps determine surgical strategy. The other thing that we need to do with surgery sometimes is remove lymph nodes. So there are 3 main lymph node basins that we have to consider when we're doing removal of skin melanoma. The upper lymph nodes that filter are the cervical lymph nodes. That's in the neck. Your head sticks out, so it needs a filter to protect the body with the lymph nodes in the neck. Then your arms stick out, so they require lymph nodes to be in the armpit that filter viruses and bacteria and occasionally tumors from the arms. Then of course your legs have groin lymph nodes that will need to be removed. So the medical terms are cervical, axillary, and inguinal lymph nodes. So this ends up on the types of reconstructions that we'll be talking about today. The first will be the muscle flap that uses the sartorius muscle, and I will show you where the sartorius muscle is after an inguinal lymph node dissection. The other reconstructive techniques where we just borrow skin from somewhere else and sew it to the empty place. There's a way to do that with full thickness or split thickness skin grafts. And then we have names for the shapes of the three main ones that we use: rhomboid flaps, keystone flaps, and pinwheel flaps. So this is a diagram showing how the lymph nodes in the groin filter the leg and the lower abdomen. What's kind of subtle and a little difficult to see in this picture is that the lymph nodes overlie the femoral artery and vein, and those are the important blood supply of the leg. The other thing that happens after we undermine that area in the groin is that it leaves a thinned out layer of skin. So this photograph on your left-hand side shows how the sartorius muscle hooks up to the hip bone, then wraps around at an angle across the thigh and goes to the inside of the knee. So that's the sartorius muscle. And if you look to the right of the picture, you see it's been separated from the hip bone and then rolled over the blood vessels to provide coverage for them. So this picture shows what it looks like after the lymph nodes have been removed from a person's groin. That's the left leg, and you can see the femoral artery and vein are exposed. So that's what it looks like with it's exposed. And then you can see that the skin overlying it is very thin. So that's going to require some protection in case that skin separates. So we roll the sartorius muscle over. Here's a larger version of that same diagram. And now you see how it's been attached, so it provides protection for the femoral artery and vein. So that's another hint that muscle is lying on top of the femoral artery and vein. So sometimes when we're following it up and getting CT scans or PET scans, that muscle will look like a lymph node lying on top of the artery and vein. And if the radiologist does not know the patient has had a sartorius flap, they will be confused and think that that's a lymph node there. So that's your other quiz question answer for the morning. And this shows an inguinal dissection after it's been closed. You see it's a large incision, and then there's drainage tubes coming out to drain the lymphatic fluid until that heals and scars down. But that's what it looks like after it's been thinned out and the nodes have been removed. So there's two kinds of skin graft that are used. The first is a full thickness skin graft, and you see on the diagram, the full thickness separates the entire layer of skin from the subcutaneous fat. A split thickness skin graft is used more often, and it can be used over the entire body. A full thickness graft is typically used on the face and hands. Those are more delicate areas. The difference is it's sometimes harder to get a full thickness graft to take. So that's why a split thickness graft is used more often for less critical areas. Here's some examples of full thickness skin grafts. Here's a full thickness skin graft on a man's nose, and then here's a full thickness skin graft on the back of a patient's hand. So the other type of graft is a split thickness skin graft, and this shows a dermatome being used to harvest that graft. A dermatome has a very razor sharp blade that slides back and forth to peel up the top layer of skin and still leave the functional dermis behind, so it heals quickly. Then the graft is placed through a mesher so that it makes little holes in it, so it looks sort of like a chain link fence. That allows for stretching and coverage so it can fit all of these odd shaped wounds better and provide coverage. So here we see a graft that's been a split thickness skin graft that's been sutured into place. So it requires a special kind of dressing to hold it in place until that skin has had blood vessels that grow from the underlying muscle into the new skin. So this diagram shows what's called a vacuum dressing. You see the black area in the middle is a sponge that sits on top of the graft, and then there's a suction tube from the top of the black area that goes to a small box that's about the size of a cigar box that the patient carries around for about a week. The sponge dressing removes the fluid and allows the split graft to stick down to the underlying tissues and have blood vessels grow into it. That's called a vac dressing. Here's what one looks like after it's been applied. You see the black sponge with the tube going to the vacuum device. And then it's hard to see in this picture, but the top layer of dressing looks like saran wrap that's glued to the skin. So it provides an airtight seal for the next week or 10 days. So the rhomboid flap is the most commonly used flap in melanoma surgery, and it works in many anatomical sites. So if you look at the diagram, the first picture shows the area that's been removed. That's the dark gray area. So then an area of the same size and shape has been marked just below it. And you see as you progress from left to right on the diagram, you see how the graft has been lifted, and then it's positioned into the empty space, and then it provides closure that a lot of patients describe as looking like the Big Dipper. The nice thing about the rhomboid flap is that it provides a full thickness of skin and subcutaneous fat. So it avoids that punched out appearance that we commonly see with skin grafts. So here is a picture where we see the lesion has been removed from a patient's back. The rhomboid flap has been marked in preparation. And then this next picture, we'll see that it's being raised. So it's being raised, and you see that the part of the flap with an X will be placed to the side of the wound that's marked with an X. And then that will pull that tissue in and allow for a closure. And that's what it looks like after it's been sutured into place. It provides a nice functional coverage. This next flap is called a keystone flap, and it's used on narrow areas like the forearms and calves. And instead of just taking a simple ellipse or circle of skin out and then trying to pull that together with the stitches, where it would create way too much tension and probably lead to wound breakdown, it spreads tension around a greater circumference. And the other thing is, since the skin flap, which is the area in the middle, is still fully attached to the underlying tissue, it keeps its deep blood supply, so it heals more quickly. Here we see an area that's been removed. This is on the back of a patient's calf, and the keystone flap has been marked in preparation. Then the keystone flap has been incised. So that middle part is still attached to the underlying tissue, but then stitches are placed around it to pull the flap into position and spread the tension out and provide a much more functional closure without a punched out appearance. This is also a full thickness type of transposition flap. The particularly difficult area is the scalp. As you can imagine, there's not much flexibility on the scalp. So we use what's called a pinwheel flap, where we have to mobilize 4 limbs of tissue that don't move very well, but each one only needs to move a little bit of the way to provide coverage. The scalp is not very pliable tissue. So this diagram shows the lesion in the middle has been removed. In the middle, it's been removed down to the periosteum of the skull. That's the coverage of the bone. But then you see how the 4 separate incisions have been made at the 12 o'clock, 3 o'clock, 6 o'clock, and 9 o'clock positions. And then each one will be rotated in slightly. And the nice thing is that this is hair-bearing tissue. So it gets rotated in, and we'll show in the next diagram. So they've all, each part has been rotated in a little bit, and then all of these areas will be attached with sutures. And that's what it looks like on the final closure. So it looks like a curvy X pattern. But what you'll also notice is that each one of those limbs has hair follicles on it, so that once it heals and the hair can grow back in, so it doesn't create a punched out spot or a bald spot. Again, this is a full thickness flap that provides good natural coverage. So here's an example of a patient being prepared for a pinwheel flap. No tissue's been removed yet. And then the scalp, because of its excellent blood supply, heals very well. And here you can see a patient that's 1 year out. This person had a pinwheel flap right at the hairline, even extending onto the forehead a little bit. And you can see that it's healed in as a full thickness and does have hair growing in there, so you can't see the flap at all. So now we're ready for our post quiz, and maybe you can help each other out, or maybe you can answer these on your own. What 2 factors determine surgical procedures? And then the second question, what type of flap can be confusing for radiologists? And here are the answers. So the 2 factors that determine a surgical procedure are the depth of invasion of the melanoma and the anatomy on the body of where it is. And then what type of flap can be confusing for radiologists? That's that sartorius muscle flap that covers the inguinal lymph nodes after they've been removed. Well, that's it for today. I'm sure you did very well on your quiz, and I'm really happy to be participating in this seminar. Thanks so much.
Well, what we're going to do next is I have a collection of questions that people submitted in advance or have been submitting online. We have over 100 attendees watching online right now. We will take questions until I get the time warning from Anne, and she's going around the room to collect your questions. This will not be the only opportunity for questions. We're gonna have a coffee break and you can ask questions in, and we have another scheduled break at the end where we're gonna have another Q&A to allow you to ask questions. We'll just do as many of these as we have time for until it's time to take a break. We had a question online just now from someone who said that they had stage 4 melanoma and the people caring for that person were not able to find primary skin melanoma on their body. And the question was, how often does this happen? And the answer is fairly commonly. We have many people in the clinic here who have stage 4 melanoma, and a dermatologist cannot find where it started from. And what we believe is that that primary, wherever it started, disappeared because of the innate immune system even before a person received a treatment. And some cells were able to escape from where that primary melanoma started. And that's why this person has stage 4 melanoma or stage 3 melanoma, and why a treatment with immunotherapy is indicated. But the data also show that people who we can't find a primary for because it disappeared innately because of the immune system, a lot of times they get really good immunotherapy responses, because if you can imagine, their immune system's already primed to take care of melanoma even before you put a drug in their system. And then when you treat them, that enhances the opportunity for the immune system to get rid of the remaining melanoma. So that was one question. I'll go to, oh, okay, so I've got some from you all, so I'll save these for a moment. This one says, how are some of these treatments improved with the use of AI? Great question. I think time will tell. I've seen several really great applications of AI in the last year. There's a lot of clinical decision support tools. One that I see used here at the Cancer Center a lot is Open Evidence, which is a product of the New England Journal now. Open Evidence provides a lot of citations to support the answers it provides when you ask it clinical questions, but it can also indicate places that have clinical trials that would be pertinent to a patient. And that's where I really see the value of AI, because when you have a rare condition or you're in a rare situation because your melanoma has changed and standard of care treatments aren't working, we may not have a clinical trial for you, but it doesn't mean that there's not a place in the country or the world with a great clinical trial. So I certainly think that AI will help us to connect people with trials better. AI is also being used in a field called rational drug design, where we look for drug candidates or different immunotherapy approaches based on modeling of the way T cells interact with tumors. In the past, we had to do all that modeling with living systems, cells in a dish, cells on a mouse model. But some of this modeling is happening in a computer. And I think that will be another way that we'll find additional treatments for melanoma. Our next question from you all. Does occasional alcohol use interfere with immunotherapy treatment? To my knowledge, the answer is no. Everything in excess can be bad. But there's this one quote from a mentor from fellowship that really sticks with me. He would get asked this question ever so often, and a person would say, well, is it okay if I have a glass of wine once a week or a beer once a week? And he looked at him and he said, well, why in the world would you take cancer treatment and extend your life if you can't enjoy your life? By all means, you should do that if that's part of how you enjoy your life. And so I actually use that line a lot because I do believe that is true. Okay, next question. Next question, how much does sugar affect our treatment? I get this question a lot. We know that tumors love sugar. Would you recommend eliminating sugar from somebody who is receiving treatment? It is true that all cells use sugar as a substrate for energy production, but it is a misnomer to think that making a severe dietary change, restricting the sugar you intake, is going to change the course of your cancer. Cancer cells, like all cells, are really good at processing sugars from carbohydrates. And so people who restrict their sugars in their diet, they're still going to have an equal amount of sugar available to the tumors. They're just going to have less enjoyment of their life because they're passing on the ice cream they were hoping for, or the dessert they were hoping for, or the soda they were hoping for. Just like alcohol, anything in excess is not good, but I think that these are the things that bring people joy. And why would you try to extend your life if you couldn't do those joyful things? So I tell people all the time, don't try to restrict the sugar you intake because there's been no evidence to date that shows that's going to appreciably change the course of your cancer treatment. The next one says, will getting a cortisone shot interfere with immunotherapy? To my knowledge, the answer is no there. It is true that when you get systemic steroids at a high dose, systemic steroids put on the brakes for this immunotherapy response that we're hoping for. But cortisone shots, it'll be in a joint space or a muscle. That steroid mostly stays where it's injected, and that's the whole reason you do it. It provides relief in the area where the injection happened. It shouldn't affect the systemic immune response to an appreciable degree, so that's still okay to do. Next question from you all. Are there any trials adding BRAF to checkpoint inhibitors? There have been trials like this, and so far, the additive toxicity of these two things doesn't outweigh any possible benefit a person can get. I think that is a common paradigm for clinical trials. If one thing works well, let's add two things. If two things work well, let's add more to that. But to date, that has shown to have a lot of additive toxicity without a lot of extra benefit, at least for melanoma. I can think of examples where targeted therapy and immunotherapy are used in other tumor types. It's just not a common paradigm in melanoma. Another person online asked the question, well, why do we use two kinds of drugs when a person has BRAF mutated melanoma? Can one drug work? Well, one drug can work. We use two drugs. One targets mutated BRAF and one targets MEK. And the BRAF drug is really the powerhouse of the treatment. MEK inhibitors by themselves for melanoma don't do much. The reason we use the two together is for two big reasons. One is if you only treat a person's melanoma with a BRAF drug, it can lead to resistance in the tumor in a very short period of time because you're only blocking one part of the growth pathway. So even though the BRAF drug by itself would work, in a period of months, that person's melanoma might become resistant to the treatment. By putting both together, some people can stay on these treatments for years. The second thing is the MAP kinase pathway is involved in other skin cancers, especially squamous cell cancer. And so if you only target the BRAF protein and not the other protein, it can lead to formation of other cancers like squamous cell cancer. So that's why we use both of those together. Somebody said, is progress being made in screening or early detection beyond the dermatology skin exam? I'm sure there's a lot of work in this space, but to date, I would say there's not as much progress as you would expect. Even the USPSTF, which is the United States Preventative Services Task Force, this is the organization of experts that gives us our recommendations about colon cancer screening, lung cancer screening, breast cancer screening. They don't have a firm recommendation that every person needs a dermatology skin exam because they're kind of weighing the possible benefits and the cost of the whole health system. So a lot of dermatologists will say if a person's had a skin cancer history, an appreciable sun exposure history, if they have a really fair skin type plus all those other things, those are the kind of people that need screening, but there's not yet a firm indication for every person needing to be screened, and there's not a lot of molecular or blood-based tests to help with that screening yet. That could change, and when it changes, we'll do it, but it just hasn't changed yet. And here's another question from one of you in the room. It says, when a person is being treated with immunotherapy, such as pembrolizumab for advanced melanoma, how can they be monitored on a regular, maybe monthly basis to avoid side effects that target the coronary arteries or the pituitary gland, which are unusual side effects but do occur sometimes? There's a lot in that question, so I'll break it apart. This person's asking about immune toxicity from immunotherapy, like pembrolizumab. We know that people who are treated with one drug have about a 25% toxicity rate. Two drugs, it's about a 50% toxicity rate. And it is true that the immune system can attack anything. We talk in clinic a lot about the digestive side effects, the lung side effects, the skin and joint side effects, but you don't have to look too far in a population of people treated for melanoma to find a very rare side effect that you wouldn't experience. I've had a few people who have had toxicity to the bone marrow because of immunotherapy. It's not something you think about a lot, but it does happen. The immune system can literally attack anything. What we do at UNM and what is really standard practice at all cancer centers is the doctor and care team see the patient before every treatment. We do labs before every treatment. We look and see, is this person having toxicities in our conversation together that everybody needs to be aware of? Do the labs reflect a toxicity that the person hasn't yet brought up but is significantly there? And so that's our strategy. And so this person asked about Keytruda or pembrolizumab. That is a drug that we give every 3 weeks or every 6 weeks. And so for the people on the 3-week strategy, they are getting seen that frequently, and their labs are being checked that frequently, and they're seeing the doctor and the nurse practitioner and the nurse and the infusion room nurse staff on a regular basis, because we are acutely aware that we don't have a really good way of predicting who are going to get those toxicities. So we have to have these regular check-ins. And are we good on time? 2 more minutes. Okay. These questions I have came from our online audience. This person says, if a patient is showing signs of tumor shrinkage early in treatment, and I'm presuming for stage 4 melanoma, is it necessary to continue long-term treatment? And what are your thoughts once immunotherapy is showing an activated immune system? As some of you know, the standard for stage 4 melanoma is to try to get somebody to 2 years of treatment. Now, that's not possible for every person. Some people need to stop early. Some people choose to stop early. Well, where does 2 years come from? Well, it's arbitrary. People thought, well, if 1 year works well, maybe 2 years works better. Number two, this is how the trials were designed. The trial that was designed for people to get treatment for up to 2 years. And I showed you in my talk that we have a 50% survival at 11 years for people that were treated in exactly that way. So now imagine a person has new stage 4 melanoma, and they know these data, or somebody's told them about these data, and they know that the standard is to treat for 2 years, and it gets this excellent treatment outcome. It's a little bit hard for people to want to stop early because they say, well, am I selling myself short? Now, they may not be, but we just don't have appreciable data yet to show us when we should be stopping. We had a study open here for a little while that would allow us to stop treatment after a year for people with a reassuring PET scan, but we had to close it because we had trouble enrolling people to it, because when people were offered to stop a year early, a lot of people said, I'm glad you all do research. That's really exciting. But for me and my journey, I kind of want to do 2 years of treatment. Thanks. Okay. The next question says, I'd like to know your thoughts about research about vitiligo prior to diagnosis. Just a raise of hands if you know what vitiligo looks like. Okay, a minority of people. You've probably seen somebody with vitiligo. So vitiligo is where the immune system attacks the skin and you see depigmentation on the skin. The most striking examples are people with really dark skin, where patches of their skin becomes totally white because the immune system's attacking the melanocytes in the skin. That's a permanent skin change. It's cosmetically not desirable by some people. But people who have vitiligo before they get immunotherapy, and especially people who develop vitiligo on immunotherapy, often have excellent treatment responses. We have a patient here who developed vitiligo on pembrolizumab, stage 4 melanoma, and it has had a complete response. And I think that person's vitiligo was a reflection of a hyperactivated immune system that allowed the pembrolizumab to do exactly what you wanted it to, which is to entirely get rid of the cancer. Okay. This one says, do people have melanocytes, which are the non-cancer melanin cells in their nose, or is it just the skin? And the answer is, it is in the nose, but not in everybody. When you're very young, it's estimated that about 20% of people will have melanocytes in the nasal mucosa. But these cells change over time, and so the percentage of melanocytes in your nasal mucosa increase with age. And I think it's estimated that close to half of people in later parts of life will have melanocytes in their nose. And the reason this person's asking is because we had this whole discussion about mucosal melanoma, the type of melanoma that happens in these sun protected regions, such as the genital urinary tract or the digestive tract or the nasal mucosal tract. And because those cells are there, that's why there's a chance that people can get cancer there. This next question is great. This one I think about a lot. Why do some people respond very well to immunotherapy while others do not? I don't have a good answer for that, but I do tell people all the time that when we have a good prediction tool to tell us whether people will have an immunotherapy response, I think that prediction tool will be a blockbuster. Number two, I think everybody will use it, because if we had a way that we could either test blood or a tumor and tell somebody, well, you have a 90% chance of having an excellent response or a 50% chance or a 20% chance, it would weight decision making in all ways. And people with a 90% chance, they would probably do treatment even with the risk of side effects, and people with a marginal benefit would choose not to do it for the same reasons. So we don't have that test yet, but I really do think that that is on the horizon, and we'll have that someday. I've got a few more questions, but I see Ann. Yeah, let's take a break now. We've got a lot of other excellent questions from you all and things that were posed ahead of time. And I've marked several of them because they're related to survivorship for the second half. So we've got more food and drink right outside. We'll take a break. And then what time do we want to be? So 10 minutes from now, we'll be back seated for the second half of our presentation. So take a break and see you soon. Okay. Yeah, you might dissect which one.
No. Okay. But you need to
Keep that. Perfect.
and,
You got it. Oh, the whole. Yeah, that was.
okay, all right, then you answer.
Well,
Oh. Yeah. I mean, she already.
oh. After the like this, yeah.
Thank you, Diane. Thank you.
What I noticed was,
That's it. There you go.
what I noticed was, if we hear the window, this is enclosed, right? So when I quit, this thing said stop. Yes, because it's in the full side. Yeah, and it's in one window. I didn't notice that previously, but. Oh. So it's moving. Okay. For everyone in the room and our online audience, we're going to get started with the second half of our symposium today. Our next presenter is Dr. Moser, who is, like me, someone who sees a lot of people with melanoma. He's at Honor Health in Phoenix. And the reason I asked him to present, besides the fact that I think he's just a really great oncologist and person, is he does a lot of phase 1 trials. He also has a FDA-approved treatment, cellular therapy for melanoma. Because we don't have this in New Mexico yet, we send a lot of people his way. And it's a whole process to understand it. And I thought this symposium would be just a really outstanding venue for all of us to be on the same page about how this works. So we have his recording, and then I asked him a few questions the day he recorded this, and you'll see him as a part of the recording. So without further ado, here he goes.
Great. Well, thanks everyone for joining today, and thanks for coming to this talk. So I'm Justin Moser, a medical oncologist who specializes in melanoma at Honor Health Research Institute and Arizona State University School of Medicine and Engineering. And I'm here today to talk about TIL therapy or lifileucel for advanced melanoma. So this is our overview for the talk today. We're going to talk, what is tumor-infiltrating lymphocyte therapy or TIL therapy? How effective is TIL therapy? What are the side effects of TIL therapy? Who is eligible for TIL therapy, and where can you get TIL therapy? So, what is tumor-infiltrating lymphocyte therapy? So, TIL therapy is actually the first cellular therapy approved to treat non-blood cancers. We've had cell therapies for blood cancers like bone marrow transplants for many, many years. This was the first cell therapy approved to treat non-blood cancers or lymphomas. And this is a one-time treatment for melanoma, but it's a very intense one-time treatment. And it's only approved for patients who have melanoma that hasn't responded to or has come back after the standard treatment options, mainly being the immunotherapies and PD-1 based. And for those who have a mutation in a protein called BRAF, those who've previously been treated with BRAF/MEK inhibitors. This is a very long process. Once you start the workup and insurance authorization, it takes about 3 to 4 months from starting that process until you actually complete the TIL procedure and infusion and recover from all the side effects. So this diagram here on the right shows the process of TIL. So the first part is to make the cells, you have to cut out part of the cancer. And that's because TIL stands for tumor-infiltrating lymphocytes. So what that means is we cut out part of the cancer and we remove the lymphocytes that are in the tumor or, quote, infiltrating the tumor. And then we grow them from a couple hundred cells to a couple billion. And the thought behind TIL therapy is that if immune cells are in the cancer, those immune cells are probably trying to fight the cancer. They're just losing in numbers. And so the whole concept of TIL is just to get a bigger army. So we cut out the cancer, we remove the immune cells, we grow them from a couple hundred to a couple billion. We then send those cells back to the site, and then those cells are infused to the patient after getting 5 to 7 days of lymphodepleting chemotherapy. And the goal of the chemotherapy is to drop the blood cells so that they don't compete with the new cells. If we just infuse the cells without chemo, those cells will not be able to survive the normal blood cells. So we give chemotherapy to make room for the cells. We then infuse the new TIL cells. And then after the TIL cells, you get high-dose interleukin-2 for up to 6 doses. High-dose interleukin-2 is one of the master kind of cytokines or signaling molecules of the immune system. And what it does is it tells T cells or lymphocytes to grow and expand. So the thought is, we drop your blood counts with chemotherapy to make room for the new cells. We give the cells, and then we give high-dose IL-2 to tell those cells to grow and expand and help them do their job in fighting the cancer. So how effective is TIL therapy? So, TIL therapy is approved in the United States based on a single-arm study of patients with melanoma whose cancer progressed on PD-1 therapy. So this could be monotherapy with nivolumab or pembrolizumab or any of the combination therapies out there. And for those who had a BRAF/MEK mutation, they had to have been previously treated with any of the 3 currently FDA-approved BRAF/MEK inhibitors. And this was a single-arm study, meaning that it wasn't randomized, and all the patients got TIL therapy. When we look at those patients treated, we see that in the study that got the provisional FDA approval, there was a 31.4% response rate. And how we define response rate in oncology and clinical trials is your tumor has to shrink at least 30%. So if someone's tumor stops growing forever, that doesn't count as a response, but clearly that is a benefit. So sometimes you'll see an overall response rate, and sometimes you'll see a clinical benefit rate. And the benefit includes the patients whose tumors stopped growing or shrunk, but just not quite enough to call it an overall response. So roughly a third of patients had a response. The most exciting thing that we saw about the publication with TIL therapy is the durability of response. So when we look at the duration of response, we see of the 31.4% of patients whose tumor shrunk, on average, or the median time, they continued to have response for 36.5 months. So this doesn't mean that everyone treated had their cancer controlled for 36 months. It means of the 31.4% who had a response, that response lasted on average 3 years. And here's the graph on the right that shows that. So these are just the patients who had a response. And you see every time a patient loses a response, the line goes down, and you see that the line hits the 50% mark right around 36 months, with some people going out almost to 60 months after TIL therapy without losing the response. So these responses can be durable. When we look at the publication for TIL, what they show is that patients who had a normal LDH, which is a blood marker we use for melanoma, or lower volume disease than the average for the study, those patients were 2 times more likely to benefit from TIL. When you look at both of those and say, who had lower, or how did the patients who had both lower volume disease and normal LDH, those patients were 4 times more likely to benefit. So what this tells us is TIL is most effective in patients with low volume disease and low or normal LDH. And that means for most patients, using this earlier rather than later is better. And I think with clinical experience, we're all seeing that patients who have had 5, 6, 7 prior lines of therapy, who have disease in multiple organs and multiple sites, a very high LDH, we don't typically see responses with TIL. So if TIL is something that you could benefit from, thinking about it early, meeting with a TIL center early to start the workup, makes you more likely to benefit from TIL if you are going to get it sometime in the future. So you got to think of TIL earlier rather than later. So what are the side effects of TIL? So the side effects of TIL is another big reason why we want to make sure we're doing TIL therapy at the right time where you're most likely to benefit. And that's because it does come with significant side effects, both with time toxicity. You have to be around a treatment center on average for about a month. And then usually you have to go to that treatment center about 4 to 6 weeks beforehand for surgery. So there's a lot of time away from home if you don't have a TIL center by you. And there's a lot of side effects from the different treatments. So in terms of the side effects come based on what part of the treatment you're at. So with the chemotherapy that's given before the cell infusion to drop your blood counts, that can drop all your blood counts, not just your white blood cell count. So one of the side effects is low platelets and low hemoglobin. A lot of patients end up needing transfusions of both red blood cells and platelets to keep their labs at an appropriate level. If your platelets get too low or you're on blood thinners, there is a risk for bleeding as well. And so we really got to make sure we watch your blood counts closely. With the low white blood cell counts, you are at higher risk for infections as well. And this can be bacterial and fungal infections when your counts are at their absolute lowest, which is kind of during the time that you're getting the cell infusion and IL-2. But you can also be at risk for viral and other rare fungal infections long term. So most patients who get TIL are on acyclovir, a medication to prevent shingles reactivation for 6 to 12 months after they start their chemotherapy. And most patients are also on medications to prevent PCP pneumonia, a rare fungal infection in the lung, for 3 to 6 months after TIL therapy as well. With one of the chemotherapies that we give, this can cause bleeding in the bladder. And so we give lots of fluid and sometimes a medication called Mesna to prevent that. And the chemotherapy, unfortunately, will cause hair loss. The hair will come back, but it will fall out. With the cell infusion, this typically goes really well. Most of the time, people only get mild fevers and chills, and that's because these cells are yours. They're your body. They're made of your own cells, and so they don't cause a lot of side effects. After the cell infusion, that's when we do the 6 doses of high-dose IL-2, and this is where the vast majority of side effects come from with TIL. And you can see the side effects of TIL depicted on the picture on the right. Probably the main side effects we see are fevers and chills. We can also see cardiac toxicity or arrhythmias. And so all patients on IL-2 are on cardiac monitors. You can get nausea. You can get hypotension or low blood pressure. And you can also get something called capillary or vascular leak syndrome. And what this is the IL-2 actually makes your blood vessels a little leaky. So the fluid in your blood vessels will leak into your legs, causing edema, sometimes leak into your lungs, causing the need for oxygen. And so these are things you have to monitor closely for. Now, if you go online and read about high-dose IL-2, you will read about how terrible it is. And that's because before we had all the immune therapies and BRAF/MEK inhibitors and all the treatments we've talked about today, the only treatment we had for melanoma was high-dose IL-2. And for high-dose IL-2 as a treatment as itself, rather than as an adjunct for TIL, we would give 14 doses. Each dose of IL-2, the side effects compound and get worse. And so we know from the days of high-dose IL-2 that the last 7 doses were the worst. But for TIL, we only get 6. And so the IL-2 is actually much better tolerated today than it was 10, 15 years ago. So reading about those side effects can sometimes misrepresent how toxic this is. But you do have to do the IL-2 with a lot of thought and a lot of preventive medications and a lot of close monitoring. With the close monitoring that we have, most of our patients do incredibly well and get all 6 doses of the high-dose IL-2. The other thing we have to talk about with any cell therapy that's approved for any indication is the treatment-related mortality. And so historically for bone marrow transplants, which they used for leukemia, they quoted treatment-related mortality around 10%. And in the study for TIL, the treatment-related mortality was around 7.5%. Now, if you actually look at the data, most of those patients died of their cancer and not from an actual side effect of the treatment. We think the side effect or the death rate from side effects of treatment is probably closer to 1 to 2%, but it is something that you just have to discuss with all cell therapies that are currently used, regardless of the indication and regardless of what the cell therapy is. So who is eligible for TIL therapy? So to be eligible for TIL, you have to be fit enough for TIL and you have to have something that we can collect from. And so the first thing is, you need to be able to tolerate the side effects, and mainly the side effects of the chemotherapy and the high-dose IL-2. As part of to be a candidate for high-dose IL-2, we have to prove that you have good heart function, which requires an echocardiogram, and you have to have an ejection fraction of at least 45% or greater. You have to have good lung function. So all patients have to get pulmonary function tests, and we need to make sure your FEV1, which is the amount of air you can blow out in the first second of exhalation, is 60% of your predicted for your age or greater. And then you have to be fairly fit. So typically for TIL patients, I ask them, can you walk a mile? And that's typically our cutoff. And then regardless of how fit someone is, we know that the fitter you go into TIL, the better. So patients who say, yeah, I can walk a mile, I tell them, okay, over the next 2 to 3 months, as we start doing insurance authorization, do the workup and do manufacturing, I need you walking a mile 3 to 4 times a week. Once you can do that, I need you to start walking 1.5 miles. I tell them to start getting resistance bands and start doing some muscle strengthening. For patients who tell me, oh, I run 1 mile a day and I lift weights at the gym, I tell them, great, start running 2 miles now and start increasing your weights at the gym. We never want someone to, go from not being active to trying to squat 400 pounds and breaking a leg, right? That's not the goal. But we do need everyone to kind of slowly try to get fitter and stronger, because the better shape you can come into the high-dose IL-2, the better you're going to tolerate it and the quicker you recover. The other thing we need to make sure that you have a large enough tumor that we can cut out to manufacture the cells. For the clinical trial that got TIL approved, they required a tumor that was at least 1.5 centimeters in diameter. Nowadays, we probably need more than that. And that's because input equals output. And for the study of TIL, they had to be able to manufacture at least 1 billion cells. When they went to the FDA approved a TIL dose of 7.5 billion or higher. So we probably need more tissue than what was required on study to be able to be manufactured so we can get the required amount for FDA. So typically I say at least a 2 centimeter lesion in diameter, but you can also have multiple lesions. So if you have two 1 centimeter lesions or two 1.5 centimeter lesions, as long as the surgeon is able to cut out multiple lesions, that's okay. We just need at the end of the day, probably a 2 centimeter sphere of tumor for manufacturing. The last thing you need to have to be eligible for TIL is have non-rapidly progressing disease, and that's just because it takes so long for manufacturing. Once we get the insurance approval, which can take a month or longer for some patients, we do surgery. And then once we do surgery, it's 5 to 6 weeks of manufacturing. And while we can sometimes do treatments in between surgery and TIL to make sure you get there, if your cancer is growing so fast that you're going to have complications and not be a candidate for TIL, then TIL is not the right option. We need to look for something else that we can do instead. So lastly, where can I get TIL? So TIL is available at multiple treatment centers, but it's authorized treatment centers only. And you can go to I think it's like TIL, you can Google TIL authorized treatment centers, and they'll have a list and a map where you can put in your address and look for the treatments that are near you. Doing a quick search around New Mexico, you see that the authorized TIL treatment centers closest to you guys are going to be us here in Phoenix and a couple others, as well as a couple of groups up in Colorado and mainly in Denver. Those are going to be the closest TIL programs available for patients in New Mexico. Great. Well, thanks everyone for joining today and listening.
Thank you so much for that presentation. Since this is going to be presented asynchronously, I've got a few questions for you that I'll ask, and we can show that your responses. That's okay with you?
Absolutely.
One question that I think might be on people's mind is, let's say they have been in immunotherapy and they have progression, but they have a BRAF mutation. And so their oncologist starts them on BRAF drug. How soon should they get referred to some center like yours to talk about TIL?
Yeah, that's a great question. Starting patients on BRAF/MEK inhibitors and timing of TIL can be a challenge. And that's just because we know BRAF/MEK inhibitors can work really well. 60+% of the time, we can have dramatic shrinkage. So sometimes patients can have disease that we can cut out for TIL, but by the time they go on their BRAF/MEK inhibitors, it's too small. But we also know that on average, pills work for 9 to 12 months. And so the timing is critical. So I think patients who have, really deep responses to BRAF/MEK inhibitors that are likely to be more durable, waiting a couple of months once they start it makes sense. I think anyone who doesn't have significant response to the pills or stable disease, get them to a center early. The other thing, which is a little squirrely, but the time of the year matters. So if you start someone on a BRAF/MEK inhibitor around January, you can send them to a TIL center. We can get authorization and everything, and that authorization will be good through the year. If you send me someone in October and I get authorization and they're on pills to the next year, some insurances make you restart that authorization at that time. And so I think timing matters, but ideally, if we can get patients in, get them worked up, get the approval in advance of them progressing, that just makes us be able to transition to surgery much quicker, especially since some patients with BRAF mutant melanoma can grow quickly once they progress on the pills. Not all of them.
Got it. And on that note regarding insurance, there's going to be people in our audience today who have a variety of insurance coverages. What has been your experience with getting this approved for patients? And is it something that can relatively take time?
In general, it is something that can reliably be approved. I think there are a couple of nuances. There are a couple insurances out there that have specific carve outs saying they don't cover cell therapy for any indication, or they don't cover transplant for any indication. A lot of times, these are the more smaller insurance companies or smaller insurance programs rather than the large ones. But I think making sure your insurance doesn't have a carve out for cell therapy or transplant is important. And then the other issue we sometimes see is state specific plans. So plans that only cover people in New Mexico, for example, when you guys don't have an authorized treatment center. That can sometimes be challenging. We are working on that. I think my site is trying to get authorized and get on all the New Mexico specific insurances so we can work around that. The other thing that's been challenging, and this is a nationwide issue, is there is an issue right now with Medicaid that state Medicaids are not covering TIL. I hope that this is an issue that can be addressed on the national level shortly, but right now it is unfortunately a nationwide issue and not specific to any state.
Okay, got it. You mentioned the chemotherapy that's involved in the process, and I think that is a source of maybe confusion, or it's not clear for patients, like why are we using chemotherapy for a melanoma treatment? Can you kind of explain what that role of that conditioning chemo is in this whole process?
Yeah, that's a great question, because we all say chemotherapy doesn't work for melanoma, which is absolutely true. But, when they first started studying TILs back in the late 70s and 80s at the National Cancer Institute, one of the first studies they showed is that if you just give TILs, nothing happens. The TILs are outcompeted by the normal cells because your normal cells aren't recently out of a freezer. The TILs are frozen, they're thawed, they're not quite robust yet, and then you're putting them in an environment of a lot of other robust cells and they just don't grow. And so TIL never really worked until they started doing things to drop the blood counts, like chemotherapy. At one point, they were doing kind of bone marrow radiation as well. That has been found not to be needed anymore for most patients. But really, the chemotherapy drop makes room for the cells so they can grow. And we know very definitively that the cells will not grow if we don't do the chemotherapy.
And because you need to isolate tumor cells, what do you tell patients who don't have a readily accessible tumor mass that can be used for cell harvest?
Yeah, so for those patients, we like to look for clinical trials. If we think that they will develop a tumor mass, or there's a mass that's close to size but not quite, then sometimes we'll keep them on their current therapy and let them progress a little more while we do workup and start scheduling surgery and kind of moving the timeline forward. Unfortunately, though, there are some patients who their cancer just isn't in a spot where we can collect it safely, and so TIL would not be an option for that.
Great. And my last couple of questions are kind of for the survivorship journey. First of all, for the caregivers in the room and the family members in the room who are wondering, what should they be doing to prepare for the helping a person with melanoma go through the process, and in the early days post cell deliveries, post IL-2? What things would you recommend that they do and be thinking of to support a person with melanoma?
Yeah, that's a great question. I think, one of the big things is, since the chemotherapy, the fluids and everything we do is very hard, it's kind of forcing people to work through it. And so we do all of our lymphodepleting chemotherapy as an outpatient. Some places do it as an inpatient. And one of the reasons we do it as an outpatient, because then the patient physically has to walk into our clinic, walk out, and walk home. And that extra activity when they're on the chemotherapy just helps them recover from the chemo. It helps push off all the fluids we're giving. And that's the same for the IL-2 and when you're in the hospital. So I think, it's supporting them through all the symptoms, but also really encouraging them, okay, you feel okay, let's take a couple walks. Even if it's, I can only walk 10 steps, great, tomorrow let's walk 12. But really, that physical conditioning part of the treatment is really important.
And then long term, for a person who's received your cells and IL-2, when do you expect a peak response from their cellular therapy? And how often should somebody anticipate getting scanned or checked to make sure things are still going well?
Yeah, great question. So while we can see responses very quickly with TIL, we've had people, in the hospital getting IL-2 2-3 days after TIL say, oh, I can't feel this spot on my chest anymore. Responses can also be delayed. And so I think, we typically do scans 6 weeks after the cell infusion and then another 6 weeks after that. And if they're in response, we transition every 12 months. There have been some reports of more delayed responses, and we know that responses can deepen with time as well. But in general, at the 6 week mark, you have a pretty good idea if someone's responding or not.
Great. Well, thank you so much for presenting for police today so that we can show this at our symposium, and we really appreciate you giving us this overview too.
Yeah, no problem. And sorry I can't make it in person.
Right. Well, we're going to go to our next presenter, and she's Dr. McEnany. She's the CEO for the New Mexico Cancer Center. She and I also work together on the ASCO, which is the Cancer Caucus delegation to the American Medical Association. She's also a former president of the American Medical Association. And I reached out to her to see if she'd like to talk about survivorship, because we will have survivors in this room and think that's an important part of their care. So please welcome Dr. McEnany.
Thank you much for asking me to be here and talk about survivorship. Survivorship is mostly a happy topic, but there are going to be a few things that I tell you that you're not going to actually like hearing. But let's get started with that. I'm going to try to go over what the reality is. Since we're here in New Mexico, I don't know where all the people online are from. They may have an easier time of it, but there's some definite things that affect us for that. That worked. Okay. So there are a lot of people out there who are melanoma survivors. That is a very good thing. Making more people survivors is a wonderful thing. That's what we're all trying to do. When we look at the number, though, and it grows over time, this is a lot of people who are living with the idea that this cancer could come back. How do I cope with that? What can I do to make it not come back? What do I do if I get another one? How should I be changing my life? Should I be going on the sugar-free diet, or should I read all of the things? There's stacks and stacks and stacks and people making fortunes with books telling you how to live your life. You don't have to read all those. You don't have to read all those. In fact, please don't, because you'll switch diets every 10 seconds and you won't have a clue what to really do. I think that the basic idea of survivorship and the goal of survivorship, and keep remembering this, is to return to as normal a life as you can so that you can enjoy your life and you can be the person you were before you dealt with the cancer. Now, nobody can actually be the same person they were before they go through cancer treatment. It does change you. There's a little PTSD there. There are a little more issues that you have to deal with. Life is like that sometimes too. And so being a survivor, first of all, it starts on the day you're diagnosed. That's the official definition. So as you start with this, you have to plan for your immediate treatment, but you have to plan for survivorship. And it's very important. So we all know that stage is important. You've heard all that through this conference. The people who have very localized disease hopefully are not going to have a lot of survivorship issues, because the cure rate for that approaches 100%. There's always that rare off one that has a relapse, but most people are going to be survivors if they're found to have an early stage melanoma. That's a very good thing. And so really, these days, what's different about melanoma, when I started out as a baby oncologist, frankly, survivorship was not a topic in melanoma, because if you got metastatic melanoma, your chances of being around very long were not great. And all of the immunotherapies and new therapies that are around are now changing that. And we have people who are around for years and decades after melanoma stage 4. So we have to combine ongoing treatment with how you cope with survivorship. So in New Mexico, that data was 112,000 new patients across the country. And that means 106,000 new survivors every year, adding to the number of people who need treatment and who need some sort of ongoing process. I won't call it treatment for survivors because it's more coping skills and a lot of other things. In New Mexico, there's 450 new cases every year. And when we estimate and find the data, it's between 8,000 and 10,000 melanoma survivors who are here with us in New Mexico today. That's a lot of people. That's a good thing. I keep saying this is a good thing to have. Now, a little bit of the part you won't like. In New Mexico, we have 42% Medicaid, and we have about 15% in health service. And Medicare spends about $13,000 a year taking care of a Medicare age patient. But when you start dropping it down to other forms of therapy, it's pretty limited. So I will back up and say it is my personal belief that there is plenty of money in healthcare. It's just all going to large corporate entities, insurance companies, and hospital systems and everyone else who is making a lot of money on it. But it's not out there for the people who you're seeing day to day, the primary care doctors who are going out of business, the people who are in the trenches trying to take care of people. They're not, I sometimes joke that the only way to actually not make money in healthcare is to actually put your hand on a patient. It's a sad thing. But this is important, and I bring it up because when you are a survivor, you are firmly embedded in the healthcare system. And the healthcare system that we have is the one you're stuck with until we figure out how to change this thing. So you need to know how to manage and navigate this system in order to take care of yourself or your loved one. So I'm going to talk a little bit about the physician shortage in New Mexico. We're struggling here. There are multitudes of reasons for this. You've read some of them in the newspapers, and that doctors are deathly afraid of being sued for a thing called punitive damages, which means that I woke up this morning and said, you know, I'm going to hurt somebody today. What doctor does that? I mean, nobody does that. So, but it gets a lot of money. And so that's been a problem. We have a very rural to frontier state. You're not going to have a dermatologist on every corner in Jowell, New Mexico. It's just not going to happen. And part of the beauty of New Mexico and the fact that we love the place is our large distances and our wide open spaces. But that means there's a long way to travel to go see somebody. Everything in life is a trade-off, including that. And how many of you actually have a primary care doctor? All right, more than I thought. I don't either. You know, and it's because it's difficult. We'll talk a bit about that. So this is a statewide access problems. When they look at the numbers, you know, they look at the numbers here in Albuquerque and they think, oh, there's plenty. But Albuquerque takes care of the whole state. So when you add up the whole state of New Mexico and we look at the number of doctors who are there to actually see a patient, that is a limited number. And we have a risk of this getting worse. Now, we helped it a bit with the bill we passed. Thank you, Governor, for getting some limits on these punitive damages. I will tell you a little story. I have lost 4 surgeons from my practice over the last 3 years. And every one of them said, it's because I don't want to walk into the operating room and think, is this the person who's going to sue me for punitive damages and take my house and my kids' college fund? The last one said, I'm 59 years old and I'm too old to start over trying to build a retirement fund. The one before that said, I don't want to be the doctor who brings down New Mexico Cancer Center. How do I argue with that? So we have to work to change that system and make it so that we can recruit and retain physicians in New Mexico. Because if you want a doctor to see when you have a problem, this is where it has to start. So we have, and practices aren't stable here. Another little side, a project I'm working on is we're creating a clinically integrated network We have 2 dermatology practices in that network, which is a clinically integrated network, is a legal structure where you can actually link arms, work together with the payers to make the payers actually pay for care. You just heard about that with TIL cells and the struggle that we have to get authorization for therapies for everything. Everything has to have authorization. Standard of care, you know, for giving somebody Pembro, we have to get authorization for that before we can do it. It delays it 2 weeks and we know they're going to apply it. I'll tell you another little fun fact from my own practice. You know, we have 27 docs. So when we get prior authorization, we succeed 98% of the time. It costs us over $400,000 a year in staff salaries to get the payers to say yes when we're playing the mother may I game. That's a waste of money. That's another doctor I could hire. So that's one of the issues that we have to face, that we're going to have to work on if we're going to have enough doctors to do survivorship processes. So who's doing it? Well, a lot of people say, well, primary care will do this. So when I was AMA president, I appointed myself to be the liaison to the Commission on Cancers for the American College of Surgeons. And they were all big on survivorship. And I thought, okay, this will be interesting. And since I'm a cancer doctor, I seemed like the logical choice to appoint. I mean, so I did. And their first thought was, well, what we want is what Medicare wants, which is a survivorship document. So let me ask a question. How many of you have a document that tells you how you're going to live the rest of your life? Yeah, I thought so. I don't either. And if I did, if somebody gave me a piece of paper that said, this is what we want you to do for the rest of your life, I would lose it by next year. It'd be someplace in my office and I'd have no clue where it was, right? So what I worked with the Commission on Cancer was the idea that survivorship is a phase of life. It's a process. It's important. It is not a piece of paper. It is a way of accessing the care that you need, taking care of yourself in the appropriate ways, working with organizations like AIM or other patient-centered organizations to make sure that you can get what you need. It is not a piece of paper. But Medicare likes that because if they have a piece of paper, they can document it, check the box, and pay the doc for the piece of paper. That provides no value to much of anybody. Another little secret. When they talk about survivorship documents, what they said that this would provide value is that you get a summary of your treatment. That is important. And you get what you actually had and what you did about it. That is an important piece of survivorship that you should all have, but you want the source document. If I'm going to treat somebody for a second cancer, I don't want somebody's summary of what happened before. I want the original path report. I want the reports of the staging CT scans and things like that, the PET scans. So, and I do want the summary of the therapies that they had. How do you get that? We try to set it up so people are given those documents and saying, this one is the important one, keep this one. Don't take your CBC from every week when you were going through therapy, because nobody cares about that. We want your path report. We want your operative report. Those are the important things. And so I think part of a survivorship program and what we try to do at our shop is to make sure that people have the important documents and they have them forever. Because if you look at how long you are required to keep medical documents, it's 7 years. And so a lot of people stop storing documents at 7 years, or they run out of computer space or whatever. And that's a problem because you're going to live longer than 7 years and you're going to want to know what happened more than 7 years ago. So you need to have that stuff. So do that. When you look at how many dermatology visits happen in New Mexico every year, it's 3,500 to 4,000. Melanoma patients ideally should have 1 to 4 visits per dermatologist every year. So if we have 10,000 survivors, that means 8 to 12 FTE dermatologists doing nothing but survivorship. And we have 40 dermatologists in the state who will actually see melanoma patients. There are a lot of people who want to fix my wrinkles, but they don't want to do the rest of things. So that's a bit of a problem. Primary care gets this issue. There's 2,400 primary care doctors registered in the state of New Mexico, but only 1,400 of them are actually practicing primary care, according to the AMA master file. And that's a low number. So where are they? A lot of them are being hospitalists in hospitals, which is not a good place to get primary care. You don't want to go to a hospital for that because that's for acute care and getting your gallbladder out and other important things that need hospitals. But it runs back to the economics of it because it's a nicer job environment when you can just be a hospitalist. But that means that the whole idea that originally started with ASCO and the American Cancer Society of when the oncologist is finished and the treatment is done, you should send them back to their primary care. Guess what? That doesn't work because we don't have any, first of all. We don't have enough. And secondly, for primary care in practice, to survive in practice, they have to see at least 4 patients an hour. 5 is better, just to pay their overhead and their medical malpractice insurance. And so therefore, the last thing most primary care people want is a cancer survivor in their office, because we got questions. You know, this hurts. Should I worry about that? This happened to me. Is this mole a cancer? What's going on here? We have questions and we're informed consumers as survivors. And therefore, we take up more time than the average primary care can give. And primary care is a specialty that's supposed to know 1,000 things an inch deep and get people to the right people who know about TIL therapies or how to treat melanomas like Dr. Savage does. You know, they're not going to be able to answer the depth of questions that you want. So that was where the document came from. Let's create a document that will tell those primary care doctors everything they need to know. Let's put in there how often you should have surveillance for things. Well, if I write that in 2026, will it still be right in 2030? I don't know. Will somebody have a piece of paper that's telling them to do the wrong thing? Possibly. So they also, primary care also needs to, and melanoma survivors need to, remember that you have the rest of your body to take care of as well. You have to get your colonoscopy and your mammogram and check your hemoglobin A1C and your cholesterol and do all these other health maintenance things that everybody else has to do as well. So primary care is pretty much overwhelmed when it comes to survivorship. So what is it that you need as a survivor? You need somebody to do surveillance for new melanomas, right? Anybody who's had one can have another one. And what this means in the real world is I tell my patients once a month, stand stark naked in front of a mirror. And I know I'm getting older too. It's kind of disturbing to stand naked in front of a mirror and see what's sagging today, but do it anyway. And look at it. And if there's a mole you're not comfortable with, take a picture of it. And so you can look at it and see if it's changing. Because what I'm telling you is that in the current environment in healthcare in New Mexico, you're going to be a bit on your own for a lot of survivorship. Because if someone calls up to my office as a new patient, and they say, I've just been told I have a cancer, we will get them in or offer them an appointment within 72 hours. If somebody calls up and says, hey, I'm moving here from another state and I had melanoma 3 years ago and I want to establish care as a melanoma survivor, you're going to be waiting months. Because I look at it as my job is to get the people who need me today in, and anybody who's doing okay is going to end up kind of waiting. That's why that's one of the things I'm telling you you won't like, is that you are not going to be at the front of our list for getting people in, because somebody who's got something immediately life-threatening, they're going to get that appointment before you are. That's actually good for you, because it means you don't need that acute appointment. But you need to do this of looking at yourself in the mirror and looking at, and if you have a spouse, significant other, somebody you trust, have them look, because you can't see your back. And you can't, unless you've spent your career as a circus contortionist, you cannot see your back and the back of your thighs very well. And so you need somebody else to look at that. And I tell people, just get in the habit of doing that. I tell them, the day you pay the mortgage or the rent, just that's your day. You'll remember it that way. We do need surveillance for recurrence. So if anyone has had a later stage melanoma, you usually have an oncologist. Hopefully you have an oncologist. And do not let go of that person. Keep them. Do not skip those appointments, because, you know, when we're under the gun to get people in, if somebody skips 3 appointments in my practice, we don't reschedule them. I can't give away the most precious commodity I have, which is time with a physician, to somebody who isn't going to use it, right? There's people on a waiting list. So if you have a doctor, keep those appointments. And the doctors will do the surveillance you need for recurrence. People need lifestyle coaching for prevention. That does not have to be a physician. The dermatologist will do it pretty well for that. But that can be the function of groups like this. Take it out of the healthcare industry and let's create something that works better for patients and doesn't cost an arm and a leg. You still need to do screening for other malignancies. You got to get your mammograms, and guys, your colonoscopies. And guys are worse at doing that. Women tend to do what they're told a little better. But you need to do that. You also are living differently now. You do need some help in psychological coping with the idea that you have had something really scary, or that you're living with something that you have under control, but every day you wake up at 3 in the morning and go, is this the day I'm going to find it's no longer in control? That's a reality. That's a new reality. And it's difficult to work with that one. But it will have an adverse effect on your life if you do not address the fact that you are living with a new set of fears and concerns. And there, again, part of our shortage is we do not have enough mental health counselors to help. And you don't need somebody, you don't need to go back and be psychoanalyzed from your toilet training at year 2, you know, but you do need to have some coping skills. And so what we've done at the Cancer Center, my Cancer Center for this, is we work with an online group so we can tap into psychologists, licensed social workers, psychiatrists from across the country, and we've set up a program to teach coping skills. How do I get through the day when I'm paralyzed by fear that this thing is going to come back? How do I live with this process? And so we've been doing this now for about not quite a year. And we have had a huge response from our patients, not just melanoma patients, but everybody who says, this is what I needed. They do 4 or 5 online sessions in the privacy of their home. And then they can say, you know, I think I got this. I'll call you back if I need more help, but we're just teaching these coping skills that nobody ever tells you about. And so that is an incredibly valuable thing. But the other thing that is organizations like this. You know, your spouse, your significant other, your next door neighbor, they're going to get burnt out on hearing you talk about the fact that you wake up in the morning and you're worried today will be the day you come out. It's like, get over it. You'll be fine. Stop worrying about that. You got to live your life. You know, all the usual platitudes you hear. You need somebody else who's living with that to know how to cope with it. Somebody else who can say, you know, I understand that fear. I do that too. And that is something that is not in the healthcare industry. So that's an important thing to consider. And don't forget your usual health care for other chronic diseases. The rest of your body still needs your attention. You need to eat a good balanced diet. You need to exercise. You do not need to go out and burn yourself up in the sun. You need to do the things that we've all been taught over life that are good for us to do. And again, I like the comment earlier of moderation in all things, that you need to, don't go on the wild diet. I'm going to eat nothing but grapefruit, or I'm never going to touch a grapefruit, because you can find a book that will tell you to do anything you want it to tell you to do. So stop looking at those. So if you are stage 4, no evidence of disease, which is where a lot of people are, you're going to have an oncologist and they're going to be looking at you. And you need to probably add to that a dermatologist every 6 months, because you need somebody who's going to look at your back and the back of your legs and look at all of these moles and be able to be available. So we have dermatologists in our clinically integrated network where we can get people with a funny mole in a week, but you need to have an in with the healthcare community to get that done. There we go. So if you're one of the lower stages, which is a good thing, this is when you really have to take control of your own health, because you may not have an oncologist who's watching you for recurrence. You're going to have to use these kind of groups of survivors to help you figure this out. If you can find the primary care doctor or a dermatologist, find yourself a dermatologist, work on that, see them at least every 6 months. Do not do telemedicine. I will tell you, telemedicine, when you take your iPhone and you're going like this to have me look at a mole on the back of your hand and I'm trying to look at it, I can't tell. I don't think anybody can tell. I don't think teledermatology is there yet. And also you want to feel it, and I want to magnify it and see if the skin lines cross it. When you go into primary care these days, they're all advertising they can do telemedicine. Don't do that. When you go in, if you're fortunate enough to have a physician appointment and they say, oh, you don't need to take your clothes off, I can listen to your heart and your lungs through your clothes, say, no, thank you. Give me that gown, even if it's one of those horrible little paper things. Open it to the back so that somebody has to go and look at your back. I will give you a secret. You can't hear that well in the lungs when you're listening through clothing anyway. You just can't. Make your doctor take off, have your clothes off and do a good exam and say, I'm a survivor, and look at all these moles. And I'm worried about this one and that one. And before you go in, you look at yourself and you draw circles about the ones that you want to remember to ask them. So take control of your own surveillance. Insist on that physical exam. It's the most important thing that you can do. I can't tell you how many times I found melanomas on the back of people who were seeing me for something entirely different. And had I examined them through their shirt, I never would have known. So don't do that. So thank you very much for listening to me.
We're going to continue our survivorship theme by having two of our Cancer Center presenters. The first one is Wanda Matuzak, and say it again? Matuzak, and she's going to present about nutrition's role in cancer prevention. And I have to say that one of the reasons we asked her to present is because this comes up every day. People want to know, what should I be doing differently with my nutrition plan while I'm going through treatment, or when I'm done with treatment, or when I'm in survivorship. So please welcome Wanda.
So bear with me, because this is my first time using technology. I went to school in the Stone Age. So in high school, computers were not an option. So we're going to change gears and talk specifically about what you can do nutrition-wise to help prevent the reoccurrence of cancer if you had, or prevent it to begin with. So people often don't realize that cancer, it can often be prevented with changes in your diet alone, and about 50%, if you work on nutrition, of cancers can't be prevented with dietary changes alone. So our learning objectives of today are to learn about 3 different things that you can do with your diet to help you prevent cancer from reoccurring or prevent it to begin with. Learn about the importance of exercise. Learn about the importance of achieving and maintaining a normal body weight, and most important, have fun. So you've often probably heard that everybody needs to increase your antioxidant and phytochemical intake. Well, what the heck are those? What are antioxidants? We hear this all the time. What are phytochemicals? So antioxidants are the natural or synthetic substances, because we can make them in the form of vitamins, such as vitamin E, A, and E, that protects cells from damage by free radicals. So free radicals are the bad guys. They occur when unstable molecules are produced by oxidation. So something gets exposed to oxygen, a chemical reaction occurs, and all of a sudden you've got a free radical. These are the guys that do damage throughout your body. So your antioxidants and your phytochemicals help prevent this from occurring. So phytochemicals are the plant-based bioactive compounds that convey beneficial health properties. And there's actually a ton of different categories of these. And so we're going to kind of walk through the different categories, because you might hear something like, oh, this is a good source of flavonoids, or what the heck are they talking about here? So when everybody thinks of beta carotene or carotenoids, we think of carrots, right? So carotenoids are a big category. Beta carotene's an example, like what you find in carrots. Okay, you've probably heard, vitamin A is good for your eyes. Well, vitamin A is actually made from 2 different beta carotene molecules, and lycopene is also another example of a carotenoid, and you find that often in cooked tomato products like spaghetti sauce. Flavonoids, that's another category, and examples of that are quercetin and hesperidin. You might have heard of quercetin and its relationship to helping you fight off viruses, and you can actually buy quercetin as a supplement in of itself. But really, you want to try to get most of your antioxidants from food first, if possible. So example of where do you find quercetin? Apples, onions, berries, green tea are good sources. Hesperidin, you can find those in like the rinds and membranes of oranges and tangerines, lemons, and grapefruit. So those are good sources. Polyphenols include things like resveratrol and halic acid. And you all have heard that, oh, red wine is good for you because it has some antioxidants. Well, red wine is a source of resveratrol, which I may be killing the name. Grapes, peanuts, and dark chocolate. So that's something to think about. Most of us think, oh, I'm dying for a piece of chocolate. You have a sweet tooth. You're like, ooh, what should I get? Well, dark chocolate has got some beneficial properties. So instead of going for, your popsicle or your Wendy's chocolate chip cookie, go for a piece of dark chocolate. Ellagic acid is another category, and you find berries and nuts in this category, as well as things like nuts include walnuts and pecans primarily, but all nuts have some ellagic acid. Okay, phytosterols are another category, and vegetable oils, nuts, seeds, and whole grains are good sources. And then finally, and I know I'm throwing a lot of information at you, isocyanates are the last category we're going to talk about, and cruciferous vegetables. We've all heard of, oh, we need to eat more broccoli. We need to eat more Brussels sprouts, cabbage, watercress, kale. These are all good sources. So how do I increase my intake of antioxidants and phytochemicals? A lot of people, I remember years ago, a friend in college goes, oh, I don't eat vegetables. I just take vitamins. The problem is that the vitamins, antioxidants, phytochemicals that we find in a natural source like a fruit and a vegetable work synergistically. We don't know everything. We're like discovering stuff all the time. So food is always better than a supplement. However, there's times where you're not able to chew raw fruits and vegetables and you want to take a supplement. So you need to think first, what can I do to eat more fruits and vegetables in general? And in particular, fresh fruits and vegetables, because they are unprocessed. So they're going to be the best source of your antioxidants and your phytochemicals. Okay. Also, to help prevent cancer, you want to kind of cut down on the processed food, which with the American diet is rather difficult, right? Everywhere you go, there's fast food restaurants. Oh, you're doing errands. I'm hungry. Well, we got Wendy's, we got Burger King, we got McDonald's. Try to plan ahead. And, you know, if you're going to take a trip, take good, wholesome snacks with you, because the processed foods, not only are they losing vitamins and minerals, they also have lots of sugar, fat, and salt. So try to avoid the fast food. Now, nobody's got a perfect diet. You're going to do, you know, sometimes it's unavoidable. You're in the middle of New Mexico, nowhere, and you need something to eat. But in general, try to avoid the fast food, the sugary drinks, the bakery goods, desserts, candy, snacks, ready-made meals. If you have a sweet tooth, which I do, try to think about, you know, making your own desserts and incorporating things like raisins and nuts and whole wheat flour, so that you can convey some beneficial, you know, nutrients when you're making something. So if you make stuff from scratch, you're better. You control exactly what you're putting into it, and you can throw in some nuts and some fruit and increase the nutritional value. You want to try to buy whole foods versus things that are already cooked for you. So try to emphasize lean meats, chicken and fish, less on the red meat, and whole fruits and vegetables. Now, a lot of us can't afford all the time to buy, you know, the organic fruits and vegetables, which have the less pesticides, but try to do your best. And if fresh isn't available, go for something frozen. Because whenever you buy canned foods, you're buying stuff that's already been processed. Most of the nutrients are already lost. I mean, the taste might be there still, right? They add some salt to it and add some preservatives, but the nutrients are lost. So in general, we should be limiting our intake of red meat. I'm not saying avoid it altogether. Some of us are anemic and we need a good source of iron, but you want to try to avoid the processed meat and limit red meat to once a week and choose lean sources. Cut off all the fat. Try to bake, broil, steam, microwave, and grill, and choose lean chicken and fish over meat. Also, most people don't realize you can get sources of protein from plant sources. So lentils, legumes, beans, these count as good sources of protein, and they also contain fiber. And most of us are not getting enough fiber. The recommendation for fiber is like 25 to 35 grams a day. You got to really work on that to get that much. You want to avoid processed meat like canned meats, lunch meats, ham, corned beef. All of those have been processed. They've got preservatives added, lots of salt. And in general, I know most of us like to have a drink once in a while. Alcohol's been directly tied to cancer, so it's best to avoid alcohol. But if you do drink, try to limit to 2 drinks a day for men. And a drink is not your large liter of beer, like my brother seems to think. 2 drinks is like, you know, if you have beer, like, you know, 2 12-ounce cans of beer. 1 drink for women is like, you know, 1 cup of wine. And I would suggest that if you do drink, wine is probably better over hard liquor, and red wine that, you know, has a little bit of the antioxidants and phytonutrients. So the diet takeaways are, you want to try to get more fruits and vegetables in. And it's not easy, okay? If we go out to eat a lot because we're all busy and we go someplace, you know, you almost have to ask for a salad with many entrees now. It doesn't automatically come. You need to choose something that's got vegetables added. You need to think when you're planning your meals, am I including a fruit or vegetable? So when you eat, if you think about trying to include a fruit or a vegetable every time you eat, it's easier. You want to try to increase your intake of whole grains to at least 3 servings or more a day. That's like 100% whole wheat bread, brown rice, oatmeal. You want to limit red meat to once a week and eat more fish and chicken and alternative sources of protein like we talked about. Avoid all the processed food. The convenience food is everywhere. There's TV dinners, not just TV dinners. There's more food that's already made up for you, or all you have to do is stick it in the microwave than there ever was. If you look around compared to 20 years ago, everything is overly convenient. But it's better to make things from scratch because you have better control of the ingredients, right? If you make a dish from scratch and you're following a recipe, you know exactly what's in it. And try to avoid alcohol. Everybody has their own thing. And if you're an avid alcohol drinker, try to limit how many days a week you drink or the quantity. So now we're going to switch to exercise. So exercise is very important to overall health, and it actually prevents cancer by decreasing inflammation, lowering your hormone levels, and improving your immune function. So the goal here, and they always tell you in terms of minutes, 150 to 300 minutes of moderate intensity exercise per week. That boils down to about 30 minutes a day. Or you can do 75 to 150 minutes of high intensity aerobic exercise. That's like running, jogging, swimming, quick biking for about 20 minutes a day. Now, some people just don't like to exercise. So any small changes that you can make into your daily routine are good. When you're at the store, park in the spot that's farthest from the entrance to the store to make yourself walk. Park across the street from where you need to go. Make, a walk enjoyable by asking a friend to go. Listen to your podcast while you're walking. Instead of making exercise a chore, try to incorporate it into your lifestyle and make it enjoyable. Try to join a gym maybe and go to some classes, some group classes with a friend. It doesn't have to be you're going to run 5 miles today. So, and some of us, that have never exercised, it's hard. It's hard to think about it. What can I do and how to build it into your daily routine? Also, the recommendation for strength training, which is basically lifting weights, resistance exercise, is twice weekly. So it's good to use free weights. I mean, if you don't have access to a gym, you don't need to go and do what the bodybuilders do and do 20 reps here and all that. You could buy simple free weights. And even if you don't use free weights, you can use canned foods and lift those. So you can incorporate simple things into your daily routine to try to get more exercise. Because they always say if you don't move it, you lose it. And you'll notice as you get older, your muscles just aren't doing what they used to be able to do. When you do go out and try to lift something, you're like, oh, this hurts. So try to incorporate strength training a couple times a week and exercise to keep your body flexible, help prevent your muscles from deteriorating, and help prevent cancer. So in summary, I know this was quick, but you want to try to get more antioxidant rich fruits and vegetables. So not all vegetables are what I would say antioxidant rich. I mean, if you're eating canned corn, you're not going to get too much in terms of antioxidants. It's processed food. But anything that you see that has dark orange, red, green colors is going to have some antioxidants. So, and if you're not a broccoli person, if you can't stand Brussels sprouts and asparagus, which I'm one of those people, there are other sources, there's other vegetables that you can get your phytonutrients from and your antioxidants. Try to cut down on your processed foods. You'd be surprised that even if you go out to eat, and let's say you go to Applebee's and order, chicken marinara or something, they're probably using ready-made processed chicken breasts that are already prepared. They're probably just warming that up. So it's always best that if you get in the habit of making things on your own and following a recipe, you could probably do better what you get at the restaurant over time, and you'll control what you're eating much better. Okay, try to get a little bit more exercise, even if that means parking farther away when you're doing errands or going to the park with the grandchild, just to get more exercise into your daily routine. And try to avoid alcohol. If you do drink, limit your drinks to 1 per day for women and 2 for men. Does anybody have any questions? I know that was quick. All right, sounds good.
Thanks so much. Appreciate it. Our last presenter, Dr. McEnany, will need to leave before we get to the last Q&A. So I'd like to invite her back up, and we're gonna have, between Anastasia, Wanda, and I, an opportunity to answer all your questions, clinical or survivorship related. But if our audience specifically has any questions for Dr. McEnany, we wanted to give you a chance to get those asked before she has to leave. So we've got a microphone here, and if you just raise your hand, you can ask, and then she can come on up and answer.
Okay. Okay, can do that. We've stunned everyone into silence. Oh, there's a question.
Because you know me. Long-term survivorship is fucking kicking my ass. And the only good thing about it is my oncologist told me that it's proof that the Pembro is working. But I got weakness, tired. My arms and legs are detached and on their own walkabout someplace, which I know is a sign that the therapy has not destroying my nerves, but you know what I'm talking about.
I hope, hopefully you listened during that last session.
Oh,
Thank you to that one, because there are people who love exercise, and then there are the rest of us, right? And it is hard to make yourself get up and do it, especially when you're going through cancer treatment. And but it's so important. And it's important to make yourself do it, even if you're doing just a little bit. We tried an experiment at the Cancer Center many years ago where we put in a whole physical therapy nutritionist department. The insurance industry killed it and they went out of business. And so we couldn't continue that, but just getting people, we called it prehab. So instead of waiting until you're debilitated, you start early and you try to build beforehand. You heard a bit of that in the lecture on the TIL therapies. I know this isn't what you want to hear. You want a magic bullet that will make it all better, but that doesn't exist. You have to do the work yourself. I know. Fatigued. Well, again, if you're on immunotherapies, you absolutely need to make sure that they're checking your thyroid levels and you're checking your pituitary levels, et cetera, to make sure that you don't have an imbalance created by the immunotherapy. They're making us all turn back into endocrinologists these days because there are so many endocrine side effects. So that would be the first thing that I would do, is to make sure that all of the hormones are in place. Sounds like you, and knowing you, you probably are doing the exercise, but making sure that you're getting a good night's sleep. There's a lot of discussion about sleep these days and how important that is, and a lot of tricks about not waking up at 3 a.m. and not being able to get back to sleep, and how you do that, which is kind of beyond the scope of this talk, but making sure that you actually get good sleep at night, not napping during the day, because then you don't sleep those solid 8 hours and get the REM sleep you need. So it's really self-inspection and see what else you can do in your lifestyle and make sure that all the hormones are where they need to be.
I basically want to say to you, thank you for the absence that you are in charge of here. Dr. Savage, the oncology team, I just don't have enough words. AI doesn't come up that to say thank you for what he has been able to get here. Thank you.
I think he is a superstar for melanoma, and Dr. Savage, you know, if UNM has their act together at all, they're gonna support you and put you in leadership positions, because I've watched him now at the AMA where he's working on the Council on Medical Education, in addition to being a fabulous melanoma doctor. And those are the kind of doctors we need, who are gonna go above and beyond what they do from, you know, it's not an 8 to 5 job. It just is not. And we need more Dr. Savages in the world. But thank you for that.
We had a few questions that were submitted ahead of time, and this one I think you would be very quick to answer. Somebody said, I'm a cancer survivor. What information does my PCP just practically need regarding my previous cancer treatment to help me?
They need the path report. They need to know what treatment you had and what long-term side effects are available for that. They need to be in contact with your oncologist so that they have a referral source really quickly. Primary care has to know about cardiology and gastroenterology and endocrinology and 8 zillion other things that when we specialize as an oncologist, we kind of put that to the side and count on someone else. That someone else has to be able to count on us when they have a question that is going to be more specific about, could this be a cancer side effect? Now, the other thing I want to say about that, when you're there with your physician and you say, I'm fatigued, the immediate reaction was, well, you had cancer, right? So you're stuck with that. And I find that there are a lot of doctors who, when they hear that someone has had cancer, they sort of stop thinking about all the other stuff it could be. Gee, it hurts here, you know, whenever I eat. Maybe you have heartburn, maybe you have gallbladder disease. Normal things happen to cancer patients too. And so don't let your doctor say, it's the cancer, or, oh, you had chemotherapy and that's why you have this other thing. It's not always the case. Say, yes, but could it be anything else?
Great. Well, thank you so much.
Okay.
I really enjoyed having you. I'd like to welcome up Anastasia Stozen. She is one of our social workers, and you know, I feel like cancer care is a team-based sport, and Anastasia helps so much in a lot of ways with people who are going through a cancer journey, and she's going to present to us on things that we should consider in that journey. So thank you.
So good morning. I'm Anastasia. Thank you. I'm one of the social workers, and we're going to finish and talk briefly about survivorship and a little bit about coping strategies. So one of the terms that you'll hear quite frequently with regards to survivorship is the new normal. And this includes returning to work, but not feeling like you're the same person. Parenting while managing different energy levels and emotions, relationships can shift, roles, expectations, and all kinds of communication patterns can change. Social life can change, wanting connection, but needing to establish certain boundaries with regards to this new normal. Fatigue and some of the invisible side effects that can come with survivorship or post-treatment. Cancer-related fatigue isn't just feeling tired. This can include brain fog, emotional exhaustion, physical limits, and the others around you may not see this particular impact. And especially I think when returning to the workforce, there's a pressure to look fine. I call it battery at 20%, and somehow the charger went missing. Processing the trauma of having a diagnosis after your diagnosis. Diagnosis can be traumatic even after the treatment ends. There can be lingering fear, anxiety. Dr. McEnany talked a little bit about hyper awareness of your body. Is this related or is it not related? Sometimes there are emotional waves, grief, relief, gratitude, sometimes feeling all of those things before lunch. And the emphasis on the importance of mental health. The overall feeling of feeling disconnected. Friends and family may not fully understand. Comments like, "You look great," can feel very complicated. Isolation, even in some very condensed social settings. Navigating kind of a new identity, patient versus survivor versus I gotta be me. Yes, I look good, but my insides are probably writing you a very different Yelp review. What we call scanxiety is very real. Anxiety before scans, appointments, follow-up, fear of recurrence can all lead to an emotional buildup while waiting and experiencing relief, or even feeling like you have more, even having more stress. This can be cyclical and ongoing. Scan week is something that some of us refer to where Googling your symptoms becomes an Olympic sport. Building a survivorship network, as Dr. McEnany was explaining to us before, peer support or online communities. There are oncology social workers, therapists, care teams. Seek out family and friends who truly listen versus try to consistently fix. Finding your people who get it and are able to support you. Palliative pain management, not just what is typically referred to as end-of-life care, but focus on quality of life, managing pain, side effects, and quality of life and comfort. Integrative approaches can also be incredibly helpful. Medication, therapy, relaxation techniques, and advocating very clearly for your needs. I think Dr. McEnany talked a little bit to us about that as well. Pain management, because tough it out is not an actual medical plan. Closing, what helps? Give yourself permission to adjust. Communicate your needs clearly, even if it feels awkward, whether it be in a social setting or when you're coming in for a follow-up medical appointment. Seek support, whether it be medical, emotional, social, and celebrate those small wins, whether it be hourly or daily. Survivorship isn't just about going back, it's about moving forward differently and enjoyably. Thank you very, very much. Thank you.
Well, our final Q&A session is almost upon us. I know you will agree with me that we have had a day filled with outstanding presentations. I want just a few minutes though to connect you with AIM at Melanoma, especially if you weren't familiar with our foundation prior to this symposium. Let me first say thank you. Thank you, Dr. Savage. Thank you to all of our presenters. This has just been an amazing day. This is my first trip to the beautiful state of New Mexico. I'll be back. AIM at Melanoma was founded 21 years ago by Valerie Guild. Her daughter, Charlie, was diagnosed with melanoma at the age of 25, shortly after she graduated from Brown University. Cancer treatment was very different then. There was only one FDA-approved treatment available for their family. And unfortunately, Charlie's tumors did not respond to that treatment. So after she passed away, Valdez founded Aim at Melanoma with two purposes. First, to find a cure for melanoma, hopefully in our lifetime. There are two things that AIM is doing I want you to know about. Firstly, Val founded the International Melanoma Working Group, which is a group of researchers, melanoma researchers across the world that meet twice a year so that they can communicate and collaborate with one another and hopefully advance a cure. The second thing that she did was to establish 5 tissue banks. And into those tissue banks go fresh frozen tissue from primary tumors that we have been gathering now for 8 or 10 years. And this year we've been asked, we have a request for our first proof of concept research. So we are moving towards that first goal. The second thing, though, is to support people who are living with melanoma. And that's what I'd like to talk with you. Again, I'm Ann Garst-Taylor. I'm the Director of Community Engagement for AIM at Melanoma. And this is my job, is to connect you with the resources that AIM at Melanoma has put together, largely through our website. And all of these resources are free. Very quickly, our website has pages and pages on the stages of melanoma, all the various kinds of melanoma, the related treatments. We have side effect management guides. We have information on melanoma clinical trials. We have a service called Talk to a Medical Expert. Melissa Wilson is an oncology PA who has worked for 20 plus years at UPMC. She is not there to change your plan of care, but rather to make sure that you understand your plan of care. In addition to the form that you can complete to ask questions to Melissa, she has done, she has a series called From the Clinic to the Living Room. She's taken questions that have come in over and over again from the public and answered those questions. Things like, what does it mean to be BRAF positive? You know, another really popular series that she did was, I've been diagnosed with melanoma, now what? So I direct you to those. They are fantastic. The other thing that we have that is so important is we have our podcast. It's called Beyond the Clinic. And this podcast is not about the clinical questions around being diagnosed with melanoma. It's about the emotional roller coaster that accompanies a cancer diagnosis. Our podcast host is Dr. Sam Siegel. She herself is a stage 4 cancer survivor. So she really comes to this podcast with a clear understanding of what it feels like to go through a cancer journey. We talk about things like building a support community, or the kinds of things that you can do to try to bring vitality and joy to your life. Whether it's journaling, yoga, all kinds of things. And she brings experts from the community to come and talk to her about those things. Absolutely fantastic. The last thing are these symposiums. We co-host 10 a year with cancer centers across the country. What we will do with the content today is what we do with all of our symposiums. We take each of the presentations, we edit them, we divide them by content, and then we put them back on our website so that you can see them again and again. In addition to that, maybe 10 or 15 minutes after we close today, this symposium in its entirety will be available on our YouTube platform, our YouTube Live platform. And Monday, I'll write to all of you to tell you how glad I am that you were able to join us both virtually and in person. And I'll send you a link to this symposium so you can watch it again. The last thing I want to make sure that you know about is our Peer Connect program. We have recruited 62 survivors, people who've completed their melanoma journey, and now they want nothing more than to be a source of inspiration and encouragement to people who are going through their treatment at this time. And that's not just people who are new to a melanoma journey, but survivors too. More and more so. Thank goodness we have more and more survivors. And so we have survivors who come to us and say, I don't know how to go into survivorship. And so then I connect them with someone. I don't want to kick anybody out of your circle of trust. I just want to add a new friend. So if you would like to have a mentor, please reach out to AIM at Melanoma, and I'm happy to do that. So how do you reach me? Here's my email address. Please reach out to me. I would love to be of service to you. And I have one more request of you. What a fantastic symposium we had today. Dr. Savage was so receptive to he asked me, what might we present on? And he was so receptive to bringing things to this symposium today that come from you, from surveys. If you look inside your packet, you'll see a survey that I have included. I need to know what you found most valuable, what we could present in the future. And that goes for you that are joining us virtually too. You'll get a link that offers you the opportunity to complete a survey for us, and I would appreciate that. And with that, it's back to Dr. Savage and your questions. Thank you so much.
I have a collection of questions here. Some are medical, some are about survivorship. We'll do as many as we can. And I have a couple that I think would be very, very well answered by our last two presenters. So I'll ask them, and then maybe you can grab a mic, or if you want to come up here and answer it, you can. But I'll tell you what it is. It says, number one, how long could it take for me to feel better and more like myself after I've completed cancer? And two, we had a question that comes up a lot about supplements. This question was specifically about ginseng and mushroom supplements, but I think people are thinking about supplements all the time. So if y'all have any thoughts about either of those, we'd love to know.
Sorry, how long would it take until I feel better after treatment? I think that's a very variable question for any individual. For some people, depending on the treatment, it can be rather quick. For some people, it's a very long, very variable process. Like I mentioned at the end of my, talk, so continue with your journey by celebrating the small wins, concentrating on enjoying the things that you do. There, from what I see, there is a big push towards exercise and wellness, not only for physical health, but for mental health. Give it a try. We have some exercise programs or exercise options out at the front signing desk, if you have it to me.
So the first thing I want to say is I'm not much about an authority on supplements, but realistically, most of us do not have a perfect diet. And there's a lot of misinformation, there's a lot of, it seems like every day there's a new supplement that's gonna fix X, Y, or Z. Realize our bodies were designed before medications and supplements were in existence. So we're designed to eat healthy food and to move. So ideally, we would try to get what we need from what we're eating. However, there's times where we're not going to eat perfectly. There's many supplements out there. The problem with supplements in general is they're not regulated by the FDA. So there's no guarantee that when you buy ginseng, that's actually what's in the supplements. If you go to your pharmacy and you get a prescription for hydrocodone, you're pretty much going to be guaranteed that you're actually getting what you're paying for. So a lot of times when people are buying supplements, I say pick a company that's reputable, that does their own studies and has, some indication that
they're doing some quality control. Two, there's a lot of supplements out there that interfere with medications. So people don't realize that, if you're on Coumadin or if you're taking other medications, that taking supplements at the same time may be interfering with your ability to absorb particular medications. So I suggest run your what you're taking supplement wise, I would talk to your pharmacist. And if you can find a PharmD, you're better off to kind of review, hey, this is what I'm taking. Is there any interactions? And you can find some stuff, you know, on the internet, but I think talking to a PharmD, a pharmacist, is your best source of information, because the reality is, how many people are taking some kind of prescription medication daily? Most of us over 50 are taking something. So I'm taking levothyroxine. I really can't eat or drink anything within a couple hours of it. If I have my cereal with my milk in the morning and then I take my levothyroxine, is that levothyroxine going to get absorbed? No. So be careful with supplements. And so I am not the authority on any particular supplement like ginseng. Realize there is a cure for everything on the internet. There is a fast cure for 30 days, you'll get this, and this fixed. In life, nothing that's really good, satisfying, wholesome, or healthy is easy. So keep that in mind.
So what we will do is, Ann and I talked, and I'll try to get through the questions I can in 10 minutes. And whatever we don't get to, we will be happy to answer those questions offline. And Ann said that we could have anybody whose question's not asked, you can email melissa@aim@melanoma.org, and that question will get to me. I'm happy to answer it. Regarding the supplements, there's also an app for your phone, and it's also a web-based website through Memorial Sloan Kettering in New York. It's called About Herbs. I always tell people to download that and type in their favorite, herb vitamin supplement and find out, what are the downsides of taking it. I'm not an herb expert either, but that's a resource that's vetted by a major national cancer center that can provide some good information. The one thing I would say about immunotherapy is we do know the gut microbiome affects your immunotherapy response. So overdoing it on gallons of yogurt or lots of probiotics certainly can decrease the efficacy of immunotherapy. So do keep that in mind. There was a question from our earlier segment. Somebody asked, can Mohs surgery be done on the vulva for melanoma in situ? Because remember, mucosal melanoma can happen in that part of the body. I asked this one to Dr. Matsumoto before he left. He said yes, and he's done that sometimes. But he also said sometimes that surgery is best done by a gynecologic oncologist. So functionally at our cancer center, the way that would work is you might get seen by Dr. Matsumoto, but if he thinks there's any chance that it's invasive, he would send that person to a gynecologic oncologist. Our next question is, does low volume disease mean less tumors? And can a 2-centimeter tumor come from 2 different organs? The answer is yes and yes. So if there's very little disease on a scan, that's how it might be described as low volume disease by a radiologist. And you can have spots of cancer in any part of the body, and it can have traveled to multiple spots from one primary, perhaps on the skin. There was somebody who said, if a person has completed a year, if a person has completed a year of immunotherapy for stage 3 melanoma, but then develops stage 4 melanoma, does the treatment timeline reset? And the answer is yes there, because it's a different stage of disease. It's a different start of a whole different journey. And so we would treat it as you do for standard of care for stage 4 melanoma, which if the treatment can be tolerated and it's working, is sometimes treatment for up to 2 years of time. Our next question was from somebody online who said, I had 7 cycles of pembrolizumab and 2 surgeries. Treatment didn't work. Now my treatment was changed to durvalumab and tremelimumab. I've had 5 cycles. The lump is shrinking. How much more immunotherapy should you get? This one is a bit of an off-label question because those 2 immunotherapy drugs that person's on are not approved for melanoma. They're approved for lung cancer and liver cancer, but not melanoma. Whoever's treating that person apparently has gotten an approval for it, which sometimes is really hard to do, and it's obviously working. I think if that person were here, we would try to still treat them for 2 years. But I just want you to know that's kind of off the normal path, because those 2 immunotherapy drugs, they have a similar mechanism to the drugs we use for melanoma, but they're not actually approved for melanoma. The next one says, can someone develop a BRAF mutation later? The answer is yes. We know that cancers change over time. Lung cancers change over time. GI cancers change over time. I generally have not seen it happen, but at the time of progression, we get a biopsy and we go ahead and retest for BRAF to know, because we have a treatment for that. And so if a mutation develops, it's good to know. Somebody from the audience says, I've lived in Australia, the UK, Canada, and Scandinavia, which is, I just have to say, congratulations. That's really nice. I wish I could too. And this person was treated for stage 3 melanoma, but the person says in the United States and in Europe, people are treated for 1 year with immunotherapy after their surgery, whereas in a lot of these other countries that they mentioned, the standard of care, a lot of places, is 2 years. And why is that? Well, originally, the Keynote 054 trial really asked the question, what is the result of treatment for 1 year? That's part of why that's the label, and that's why it's done this way in the United States and Europe. The second answer is, I think there might be sometimes variability in how people practice, and maybe a little bit of lack of clarity in what the trial actually did. In the trial, people who had outright stage 3 melanoma only got treatment for 1 year. If they had unresectable disease, but it was still stage 3, or recurrent stage 3, those were the population of people who got treated for 2 years. But I think other people have extrapolated to say, well, we'll just treat everybody for 2 years. A year of immunotherapy can cost $250,000 to $500,000. 2 years for sure is $500,000. So I think we want to provide the best treatment benefit to people, but I think everybody's trying to be aware of what the costs are to not just you, but the entire health system, and the many different ways it's funded. So I think if we can expose people to less toxicity, including financial toxicity, and give them the same benefit, I think that's what a lot of people are trying to do, which is why we generally treat people for 1 year with stage 3 melanoma. Somebody says, I wouldn't be eligible for TIL, or I've been told I'm not eligible for TIL that Dr. Moser talked about because I have brain involvement. Please help me understand why. So that, as it's written, is not quite correct. People who have brain metastasis from melanoma can be treated with TIL. It just has to be well controlled at the time they do TIL. It's not that it's an exclusion, a hard exclusion. It just means the brain involvement needs to be treated, and that's what we do all the time. And when it's well controlled, they would be a candidate for TIL. And I'm going to go to the list of questions that I have. And okay, still got time. Okay, so somebody asked a very practical survivorship question. They said, my father died of melanoma. I had an early stage melanoma and I had it treated. My children are concerned about getting it. Other than annual skin exams and getting myself checked regularly and practicing good sun safety, what else can I do? For the person who wrote this, I think that person is doing all the right things. Most melanomas are not hereditary. And the biggest risk factors that we know about for cutaneous melanoma are skin complexion and lifetime sun exposure. People who get a lot of sun in their teenage years oftentimes get melanomas in their 50s, 60s, and 70s. I think this person's doing everything right. Getting yourself checked regularly if you know you have the sun exposure history is really important. The American Academy of Dermatology has a lot of really great guidelines on how to protect your skin. I point people to the weather app on their phones, because the weather app will tell you what the UV index is at any time. And if it's below 2, it'll outright tell you on the weather app, you don't need to use sun protection right now. So it's a little deceiving in New Mexico where it's sunny all the time. And you're like, gosh, I need to be wearing sun protection from the time I wake up to the time I go to bed. And that's not true. You can actually check the UV index. And if the UV index is low, even if it's bright outside, then you don't necessarily have to do all the sun protective things. The American Academy of Dermatology says the best sun protection is actually clothing. There's a lot of UV rated clothing now, long sleeve shirts, neck gaiters, hats that are really, really great. In addition to sunscreen for parts of your body you cannot put clothing on. One thing I've seen some people with melanoma describe is they have incredible anxiety about being in the sun given their history. And I would imagine there's some people in this room that can relate to that. And I just want to say that I can completely understand that. But just like we mentioned, dietary indiscretion or alcohol occasionally earlier, I think that you all and the people online, you're going through the treatments you are because you want to live a long life. And part of living a long life and enjoying it is getting outside and enjoying outdoor activities. So this should not be a sentence to stay the rest of your life indoors. We just have to figure out ways to practically get outside and be safe with your skin. Somebody asked, how can survivors move beyond being, I'm a cancer patient, to being a person who had cancer? I think you heard from Anastasia, especially, and Dr. McEnany about ways to do this, about taking care of your whole body, about exercising, about making your identity not just your cancer journey, but everything else you do, your recreational activities, your occupation, your family. I think that's really important. But I also think it's incumbent upon the friends in your network and your healthcare providers to use patient-centric language. I catch myself all the time, and I really try to catch myself. So, I don't want to describe somebody as being a melanoma patient. I want to say this is a person who had melanoma, because it's a very different framing, and it really takes into account the whole person, not just the one disease that they're having to deal with right now. There was one last very unique question that somebody wrote that has come up, and I just wanted to address it. Somebody said, when can I get pregnant following treatment for melanoma? And do I need to change any of my follow-up as a result? You do not want to be trying to achieve pregnancy or be pregnant while you're on immunotherapy, because immunotherapy can affect the placenta and it can cause a miscarriage. So that's a reason that we do pregnancy testing on people who are very young with melanoma. That being said, if a person has completed her treatment journey and is in surveillance, it's very reasonable for that person to do family planning and have a pregnancy if that's her wish. And hopefully there won't be a recurrence in that 9-month period of time when that person is pregnant. And if that doesn't happen, then great. And if it does, we have ways we can manage it. We have had a few people here with pregnancy and melanoma, and there's ways that we can work around it and try to get that person the care they need, but it becomes more complicated. But I think the gist of this is the person says, I'm a survivor, can I do natural family planning? And the answer is yes. Are there any other questions from the audience? Okay, well, before we end, I first want to say thanks again to Anne from AIM at Melanoma. I also want to say thanks to Natera. Natera is a circulating tumor DNA testing company, and they had a table in the front with some information about what they do. And Dylan from Natera is here, and they provided some financial support to make this possible. And I just want to acknowledge you all and say thank you so much. And then to our presenters who helped present today, it wasn't just you being here today, but I know you all spent a lot of time preparing these things, and the same is true for Dr. Ridgway and Dr. Moser. So we just want to express a lot of gratitude to them. And then Joanne might be outside, but Joanne is a staff member here at the Cancer Center, and she was really an integral part of making this happen. When I told the Cancer Center I wanted to do this, Ann and I started having meetings. We figured out a speaker lineup. The Cancer Center okayed their support for it, but we're all so busy, and it really took having a team. And here's Joanne here in the back, and I just want to clap for her. Because she took meetings with Anne, she took meetings with both of us. She made sure all the logistics for today worked out. She was messaging me late yesterday to make sure we had the last final details fixed for today. And it was very, very successful in a large part because of you. So thank you so much, Joanne. Okay, well, please do fill out the survey that Ann talked about. There's probably some more food and coffee outside. Please take it with you. And we are, that's it.